evening, everybody. If I could get your attention
for just a minute, we had set aside time for a business meeting tonight to talk about a subpoena that we thought we were going to need to issue. We asked for some information from the department almost a year and a half ago. Miraculously, it appeared today. So that negates the need for us to move forward with a subpoena on that particular issue. So we will not be having the business meeting that we originally had noticed and talked to everybody here on the committee, and I appreciate it. Good evening, everybody. I want to welcome you again to tonight's hearing entitled Oversight Hearing on Data Manipulation and Access to VA Health Care, testimony from GAO, the IG, and from VA. And tonight we are going to address ongoing issues of systematic wait times, manipulation that occurs throughout the Veterans Health Administration and negatively impacts the veterans that we serve and the health care that they should be provided. VA wait times and scheduling issues have been the subject of numerous investigations by the committee for many years. We have many outstanding requests for information and have held hearings to address the problems within VA that have led to veterans waiting so long for needed care. The VA's Office of Inspector General has also repeatedly warned the VA about its substandard scheduling practices. From as early as 2005, in numerous reports, VA OIG has noted that medical facilities did not have effective electronic waiting list procedures. Their outpatient scheduling procedures needed improvement nationwide. Their data was often unreliable, and they overstated their success regarding patient wait times. In December of 2012, GAO found that VA's reported wait times remained unreliable. VHA's policy continued to be implemented inconsistently across VA. Schedulers, in fact, lacked proper training, and VHA's appointment scheduling system was outdated and inefficient. Despite these repeated warnings that have come from Congress, from the GAO, and even from VA's own investigative body, issues with patient wait times and scheduling remain a pervasive problem today. Last year, this committee requested that GAO conduct a separate investigation to confirm the extent of problems throughout the VHA regarding ongoing issues with patient wait times and consult delays. GAO will testify as to its findings here tonight. Recently, the committee received whistleblower complaints regarding the Phoenix VA health care system that explained how the facility was keeping numerous wait lists to give the impression that its wait times were much shorter than they actually were. One of the secret wait lists at the facility, sources found that as many as 40 patients may have died while they were awaiting care. After the committee was able to confirm these allegations, we made the issue public during our April 9th, 2014 hearing. At that hearing, I asked that the VA OIG look into those allegations which prompted its investigation. The interim results of that investigation were released on May 28th of 2014. In that report, the OIG substantiated a number of problems at the Phoenix VAMC, but also noted how it has opened or has planned to open investigations into 42 different VA medical facilities. The OIG found that at Phoenix, at least 1,700 patients who were waiting for a primary care appointment were not on the electronic wait list, meaning that these veterans may never receive such an appointment. Additionally, OIG found that the Phoenix leadership considerably underestimated new patient wait times, which it noted is its metric used to consider bonuses and salary increases for VA employees. VA OIG also stated that inappropriate scheduling practices like those found in Phoenix are systemic across the Veterans Health Administration. Finally, we were notified earlier last week that VA would provide the findings of its internal audit of appointment wait times by last Friday. VA provided us with those findings earlier this afternoon. Tonight, I look forward to hearing what VA has to say about its audit, how it plans to repair the damage it has caused by tampering with veterans' access to care. And with that, I now yield to the ranking member, Mr. Michaud, for any opening statement he may have.
Thank you very much, Mr. Chairman, for having this hearing this evening. There is nothing more important than the welfare of the men and women who have served this country with honor and distinction. I'm pleased our committee is continuing to move quickly and in a bipartisan manner to investigate the many serious shortcomings within the VA, especially those regarding access to health care. Now is the time for us to identify the problems so that we can move forward and implement changes. That means working together on oversight and legislative solution. It also means having very frank conversation with veterans about their personal experiences, so we know how we can improve the system. Over the years, this committee has identified and helped fix many of the problems within the VA, but the VA is clearly facing a crisis that is now being addressed by the media and our increased oversight efforts. In this environment, it is especially important that we are fair in our oversight and measured in our responses. But above all, we must never fall short of doing what we need to ensure that veterans have access to the health care system that they've earned and deserve. It is important for us to work together to achieve the VA we envision. We must work together across the aisle and across the branches of government to fix these problems and ensure that the VA is caring for our veterans. When we work together, this committee works best. We know that the work that we must put forward, that we must ensure that the VA is receiving the necessary assistance and resources that they need to do what they have to. As I see it, there is critical questions that should be asked by this committee, questions that get to the root causes of the problems, questions related to the broad strategic changes needed at VA, changes in the leadership climate, encouragement with other agencies like DOD and HHS, increased utilization of the private sector, and long-term resource planning. We need to ask the hard question, what should the department look like in the future? These are not easy questions, nor do they have easy, simple answers. But today, more than ever, we must ask these questions and come up with these answers. I believe thoughtful, measured, sound policy is needed today more than ever. The answers need to be comprehensive and, when necessary, nuanced. For example, when holding leaders accountable, we need to not only focus on career senior executive members, but also the doctors and nurses who occupy administrative or executive leadership positions. As I mentioned earlier, H.R. 4399 closes a gap in the current package of legislation being considered by the House and the Senate. Mr. Chairman, I've always been proud of the bipartisan nature in which this committee has operated. My hope is that we'll continue that spirit, working together to help identify the problems and working towards a solution. No single individual has a monopoly on the answers, and no single individual or institution has all the answers. The work ahead of us will be hard, and it will require all of us to work together in that regard. The Veteran Service Organization, the Department, this committee, the Senate, and the White House. And Mr. Chairman, I want to thank you once again for your robust advocacy for our veterans in holding all these hearings that we're having for the oversight. And it's my hope that when the committee asks for information from the Department of Veterans Affairs, that they provide that information in a timely manner so we will not have to issue subpoenas to get the information that we need so we can do our oversight hearings. That's our responsibility, and we expect the department to help us do our oversight hearing as well. So with that, Mr. Chairman, I yield back to balance my time.
I thank you very much for your comments this evening. I would ask that all members would waive their opening statements as customary in the committee. I would invite now the witnesses to please come to the witness table, and as you're coming forward, I will introduce you. Tonight we're going to hear from Dr. Deborah Draper, Director of Health Care for the Government Accountability Office, Mr. Philip Makowski, Assistant Deputy Undersecretary for Health for Administrative Operations of the Department of Veterans Affairs, Richard Griffin, Acting Inspector General of the Department of Veterans Affairs. Mr. Griffin is accompanied by Ms. Linda Holliday, Assistant Inspector General for Audits and Evaluations for the Department of Veterans Affairs. I would ask the witnesses, if you would, to please stand, raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you very much. Please be seated. All of your complete written statements will be entered into the hearing record. Thank you for being here tonight, and Dr. Draper, you are now recognized for 5 minutes.
Chairman Miller, Ranking Member Michaud, and members of the committee, I appreciate the opportunity to be here today to discuss the ongoing difficulties that veterans are experiencing in obtaining needed medical care. In 2000 and 2001, we reported problems with wait times and medical appointment scheduling in VA medical facilities. In 2012, we again reported problems, including the unreliability of outpatient medical appointment wait times and the inconsistent implementation of VA scheduling policy, which impacted the timely delivery of care. We are currently conducting work examining VA's management of outpatient specialty care consults, a type of medical appointment, and have again identified problems that may hinder veterans' timely access to care. Across our body of work on access to VA health care, several common themes have emerged. These include weak and ambiguous policies and processes, which result in significant variation, confusion, and increased risk of undesirable practices at the local level. Software systems that do not facilitate good practices, inadequate training, unclear staffing needs and allocation priorities, and inadequate oversight, which relies largely on facility self-certification without independent verification, and the use of unreliable data for monitoring. My comments today focus mainly on preliminary observations from our ongoing work examining VA's management of specialty care consults. We found most of the 150 consults we reviewed were not managed in accordance with VA's timeliness guidelines. Specifically, we found 1 in 5 consult requests were not triaged within the 7-day guideline. We also found 38% of the consults were completed, but not within the 90-day guideline. 19% were completed within 90 days, but the provider failed to properly close out the consult in the electronic system. And the remaining 43% were closed without the veterans being seen. VA Medical Center officials told us that increased demand for services, patient no-shows, and canceled appointments are among factors that lead to delays and impact their ability to meet VA's 90-day consult completion guideline. During the course of our review, we also identified 1 consult in which the veteran experienced delays and died prior to obtaining needed care. I want to walk through the timeline of events for this particular case. In September 2013, the veteran was diagnosed with 2 aneurysms. In October, the medical center scheduled the veteran for surgery in November, but the surgery was subsequently canceled due to staffing issues. In December, the medical center approved non-VA care and referred the veteran to a local hospital for surgery. In late December, after the veteran followed up with the VA Medical Center, it was discovered that the non-VA provider had lost the veteran's information, which the medical center then resubmitted. In February 2014, the veteran died prior to the planned surgery at the non-VA provider. This particular case is insightful for a number of reasons, including that while non-VA care may expand capacity, there are also some potential pitfalls. For example, non-VA care requires prior approval, which may delay care. More coordination is needed between the VA Medical Center, the veteran, and the non-VA provider, and wait times for non-VA care are not tracked by VA. Our findings relative to our ongoing work include variation in how medical centers have implemented new business rules for specialty care consults, which limits the usefulness of the data for monitoring and overseeing consults system-wide, and an overall lack of oversight of the process, including no independent verification of medical centers' actions. As the demand for VA health care continues to escalate, it is imperative that VA address its access to care problems. Since 2005, the number of patients served by VA has increased nearly 20%, and the number of annual outpatient medical appointments has increased approximately 45%. In light of this, the failure to address a VA to address its access to care problems will considerably worsen an already untenable situation. Mr. Chairman, this concludes my opening remarks. I'm happy to answer any questions.
Thank you very much, Dr. Draper. Mr. Mikowski, you're now recognized for 5 minutes, and I understand you don't have prepared comments, but you are prepared to make some comments.
That is correct, sir.
You're recognized for 5 minutes.
Good evening, Chairman Miller, Ranking Member Michaud, and members of the committee. No veteran should have to wait unreasonable time for their care. They have earned this care. America's veterans deserve better. Secretary Shinseki and Acting Secretary Gibson have stated that we now know that within some of our healthcare facilities there are systemic and totally unacceptable lack of integrity. This is a breach of trust. It is irresponsible, it is indefensible, and it is unacceptable. I apologize to our veterans, their families, and their loved ones, members of Congress, veteran service organizations, our employees, and the American people. After this committee raised the issues in Phoenix at the VA healthcare system in mid-April, Secretary Shinseki directed a nationwide audit. I will be talking about that audit tonight and answering some detailed questions. This audit visited over 700 locations, involved over 400 of our national and field staff at the senior executive level, senior manager level, and frankly, line management level. We interviewed over 3,700 frontline staff members. We saw this as the opportunity for us to set a reset, to sweep away and establish a clear-eyed assessment of our actual performance, not our reported performance, and to establish a system-wide understanding of the change we needed to realize in our agency. We released our results this morning on all VA medical centers, all CBOCs, most mid and small CBOCs, and these results from this audit confirm the OIG interim report, our May 3rd initial release, and frankly, the GAO studies. I'm here to answer questions about this audit and other concerns. Our audit revealed a number of things. Number one, we have hard-working staff on the front line who work in a high-stress, complicated environment with, quite frankly, completely outdated technology. The most frequent challenges cited by our staff are, frankly, a lack of appointment slots into which to schedule veterans. They have a difficulty understanding our policies, and they rely on an antiquated system that requires numerous workarounds by well-intentioned staff. I have to admit that unfortunately we found that our staff had received instructions to enter a date other than the date a veteran wanted to be seen. We know there is an integrity issue here among some of our leaders. We can and will address this issue. I want to make a comment about reprisals against employees. Acting Secretary Gibson had mentioned this, that it is not tolerated in our system. We need our staff at all levels, but most importantly, at the point of care. We need them to tell us how to improve our system to be able to deliver care better for veterans, and they must feel safe to identify problems, and they must feel empowered to find solutions. Acting Secretary Gibson has announced immediate actions. We will expand and create new veteran satisfaction surveys for patient care. We will begin with veterans and their perspectives. We are holding senior leaders accountable. All of our senior leaders in the field over the next 30 days are expected to inspect their practices in their facilities and to be personally accountable for the integrity of those practices. We removed the 14-day scheduling goal from employee performance plans. We are increasing the transparency in the reporting of our data, and we will be releasing our access and timeliness data bi-monthly from here on out. Acting Secretary Gibson also announced an independent external audit of the integrity of our scheduling metrics. We're deploying a team to Phoenix to fix all aspects, not just their scheduling and access management practices. And we're formalizing a process for those high-performing sites in both quality, access, and integrity to be able to provide guidance and leadership to our staff and facilities that require support. We have directed staff to Phoenix to hire additional staff, to bring in temporary clinical staff, to bring in mobile medical units that are currently on the ground, to increase local contracts to include for primary care. And we are removing leadership where appropriate. We have suspended all SES performance awards for FY14 for VHA. And we are freezing hiring for VISN and VACO staff so that we may focus our HR hiring efforts on bringing on needed clinical, engineering, and administrative staff to the field. Secretary Gibson will travel to a series of VA facilities over the next few weeks to meet with veterans, their families, employees, and to identify obstacles to timely quality health care. Secretary Gibson has said that we must restore America's trust in VA healthcare system, and we must restore that one veteran at a time. Our dedicated workforce, over a third of whom are veterans, are engaged. Mr. Chairman, thank you for your dedication to and your care for our nation's veterans.
Mr. Griffin, you're recognized for 5 minutes.
Chairman Miller, Ranking Member Michaud, and members of the committee, thank you for the opportunity to testify tonight to discuss the interim results of the Office of Inspector General's work related to delays in care at the Phoenix healthcare system. I'm accompanied by Ms. Linda Halliday, Assistant Inspector General for Audits and Evaluation. The issue of manipulation of wait lists is not new to VA, and since 2005, the OIG has issued 18 reports that identified at both the national and local level deficiencies in scheduling, resulting in lengthy wait times and a negative impact on patient care. We are using our combined expertise in audit, healthcare inspections, and criminal investigators to conduct a comprehensive review requiring an in-depth examination of many sources of information, necessitating access to records and personnel both within and external to VA. We are charged with reviewing the merits of many allegations and determining whether sufficient factual evidence exists to hold VA or specific individuals accountable on the basis of criminal, civil, or administrative laws and regulations. Veterans who utilize the VA healthcare system deserve quality care and timely care. Therefore, it's necessary that information relied upon to make mission-critical management decisions regarding demand for vital healthcare services must be based on reliable and complete data throughout VA's healthcare networks. To date, we have ongoing or scheduled work at 69 VA medical facilities and have identified instances of manipulation of VA data that distort the legitimacy of reported waiting times. When sufficient credible evidence is identified supporting a potential violation of criminal law, we are coordinating our efforts with the Department of Justice. Our work to date has substantiated serious conditions at the Phoenix healthcare system. We identified about 1,400 veterans who did not have a primary care appointment but were appropriately listed on the Phoenix electronic wait list. However, we identified an additional 1,700 veterans who were waiting for a primary care appointment but were not on the electronic wait list. We reviewed a statistical sample of 226 Phoenix appointments for primary care in fiscal year 2013. VA national data, which was reported by Phoenix, showed these 226 veterans waited on average 24 days for their first primary care appointment, and only 43% waited more than 14 days. However, our review showed that those 226 veterans in our sample waited on average 115 days for their first primary care appointment, with approximately 84% waiting more than 14 days. We did not report the results of our ongoing clinical reviews in our interim report as to whether any delay in scheduling a primary care appointment resulted in a delay in diagnosis or treatment, particularly for those veterans who died awaiting care. The assessments needed to draw any conclusions require analysis of VA and non-VA medical records, death certificates, and autopsy results. We've made requests to appropriate state agencies and have subpoenas to obtain non-VA medical records. All of these records will require a detailed review by our clinical teams. While we make recommendations to the VA in our final reports, we made 4 recommendations to the VA Secretary for immediate implementation to ensure veterans receive appropriate care. We will address the sufficiency of VA's implementation of these recommendations in our final report. Our recommendations include taking immediate action to review and provide appropriate health care to the 1,700 veterans identified on not listed on the waiting list at Phoenix, and to take the same action at all facilities in the VA system. Mr. Chairman, this concludes my statement, and Ms. Halliday and I would be pleased to answer any questions.
Thank you very much, Mr. Griffin, for your testimony. Members, we will all do a round of questions at 5 minutes apiece, and we will do a second round, I'm sure, after the first round. Dr. Draper, in your comments, you said that 43% of the consults you reviewed were closed without the veterans being seen. Can you give me an explanation as to why the care wasn't provided?
Yeah, there are various reasons. One is patient no-shows, canceled appointments, and this is canceled either by the patient or the medical center. And we also found instances of, some records we couldn't tell. We looked at it, and there was no documentation as to why the consults were closed.
Mr. Murkowski, how does VA schedule appointments? Is it through a telephone call to the veteran, or is it by a letter?
It is typically through a telephone call with the veteran. The veteran may call us. We may call the veteran. We will notify the veterans on a recall reminder process, which does involve a letter, sir.
That's interesting, because I've heard numerous veterans tell me that they receive letters telling them when their appointment will be, and not asking whether or not they can attend that particular appointment. So I'm a little confused.
Sir, I've heard that as well. That is not appropriate. That increases our rate of no-shows. It is not veteran-centric. We need to change that. We should be having a conversation with a veteran, asking him or her when they want to be seen, and then scheduling around their requirement.
VA has consistently stated that the alternate list or secret list in Phoenix that was being used to populate the electronic wait list was destroyed immediately after the EWL was populated. So my question is, was there any independent verification, in fact, that every veteran on the alternate wait list was successfully transferred to the EWL, or can you provide any documentation or assurance to us that no veteran was left off the alternate wait list?
I've had a team on the ground, sir, reviewing their practices and their scheduling processes. I have a report that's only their first draft report. I'll get a final report from them, and I'll be able to dig a little bit deeper. At this point in time, I don't have any reason to believe that any veterans were left off the final EWL count, but I will wait for the final report, sir.
Can you tell the committee who at the central office, if anybody, knew or instructed or coached anybody how to manipulate wait times?
I do not know if anyone had done that, sir, not in my direct experience.
So you don't know whether they have or they haven't?
I certainly hope they have not, sir. That would run counter to our policy.
They have not either.
I certainly hope not.
In a brief in May of 2009, Dr. Mike Davies, the National Director of Systems Redesign, indicated there were 49,743 veterans waiting for care as of September 15th of 2008. Now, more than 5 years later, VA's audit shows, and has been reported in the media, that it has risen to 57,000 veterans waiting more than 90 days for their first appointment, and an additional 64,000 veterans that appear to have fallen through the cracks. How can this be?
The correct use of the electronic wait list is the number that's 57,000, sir. We use the electronic wait list if we are unable to schedule a veteran who's receiving their first specialty care consult within 90 days. The correct use of that is to ensure that we can work a veteran into an appointment sooner. The 57,000 number is a much more conservative number. The known direct clinical care is only 40,000. We have to get eyes on the EWL. We have to manage it. We have to make sure that our frontline staff and our medical centers are accurately working that list, getting veterans from waiting for an appointment into an appointment. As for the 64,000, that was the new enrollee appointment request list. Mr. Griffin had told us that that was one of the recommendations, that if we could find that in Phoenix, that we should look across the entire country. As we had a team review the new enrollee appointment request list, we identified every single veteran from the beginning of the period of enrollment who may have at one point in time requested an appointment at a given facility where they provided their enrollment data. If we could not verify that they had an appointment, we went ahead and added them to the list so that we can begin contacting them tomorrow.
Mr. Griffin, one final question before I yield to the ranking member. Have you found evidence of criminal activity in your assessment?
We have found indications of some supervisors directing some of the methodologies to change the times. We have been in discussion with the Department of Justice concerning those and whether or not, in the opinion of the Department of Justice, they rise to the level of criminal prosecution is still to be determined in most instances.
I appreciate you talking with the Department of Justice. The committee has written a letter to them also asking that they open an investigation. We haven't heard anything from them to date other than the fact that they got our letter, but I appreciate it. Mr. Michaud.
Thank you very much, Mr. Chairman. Dr. Draper, in following up on a question the chairman asked about the VA closed consultants due to no-shows, what percentage were no-shows versus VA canceling?
Well, we looked at no-shows and cancellations, and we went through the 150 consults and did a research all consults, the 150 cases that we looked at, to look at the history of the consult requests. And we found that more than half either had a no-show or a canceled appointment. So that's a large percentage of the consults. So it's a big problem for VA, and what we see is that the policies at the local level vary as to how the local facilities handle no-shows and canceled appointments.
Okay, thank you. Mr. Mikowski, GAO reports that wait times are generally not tracked for non-VA care. Why don't you track wait times for non-VA care?
Historically, sir, we have not, Congressman Michaud. We have two initiatives, both of them in full deployment at this point. The first one is for non-VA care coordination. Effectively, what is occurring now is when we refer a veteran to care in the community, if we cannot provide it, it creates an appointment inside a clinic that allows us to monitor that and watch that appointment. We are now collecting timeliness data on that. We also have a nationwide contract called Patient-Centered Care in the Community. That contract has a performance requirement from our two contractors that they both schedule and see veterans within 30 days of the referral from us. We think those two approaches will help us in the long run ensure coordination and management of non-VA care. Dr. Draper also alluded the requirement to manage the coordination of that care. It's not enough just to refer care into the community. We do need to follow through as well, ensure that the veteran's needs are met, that that non-VA provider is respectfully working with the veteran, her or his family, to get into care.
Thank you. The GAO also reports that there is a consistent problem across VHA with policy and procedures for handling no-shows and canceled appointments. I'm aware that that you are working on an update to this scheduling policy. When do you anticipate this revised policy to be released? And will it address the no-show consistently throughout the VA system and canceled appointments?
I expect it will, sir. We had a team last week reviewing the existing policy we have today and to determine whether or not we should rescind that policy and replace it with a clear, declarative set of instructions for our schedulers in the front line. We expect to take that action. We will replace that policy with a revised policy that allows us to have much more concrete sets of instructions on how to schedule, specific instructions for what to do for staff if we're scheduling within 90 days, what to do on day 91, to actually offer that specific instruction and tie that policy to training. A lot of our current policy mixes two concepts, scheduling and practice management, and we're going to have to make sure that we have a clear scheduling policy and a clear practice management policy. Management of no-shows can be handled by contacting veterans, working with veterans to ensure that they're reminded of their appointment, frankly, making sure we talk to veterans and their families when we schedule their appointment. When we do those things, we can reduce our no-shows.
Great. Can you explain to what extent exercising non-VA care requires additional approvals?
Yes, sir. In some of our medical centers, they require approval at the chief of staff level to use non-VA medical care. As part of accelerating care, we worked on that in I think the second to last week of May. We worked on the plan May 21st and rolled it out May 22nd and began execution on the 23rd of May. We have released instructions to the field that particularly where we have confidence in our wait time data, that the field is required, if they cannot offer that care in the VA facility, first they must assess their capacity, increase their capacity by running nighttime clinics, overtime, weekends, and if they cannot, then they are instructed to offer non-VA care to the veteran. And then we've asked them to tell us, what do you need in terms of resources to make that work? So we are providing a different set of instructions. To work with the veteran, it is a veteran's choice to get timely care and to make sure we offer it.
Thank you very much, Mr. Chairman.
Mr. Lamborn, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate the work you're doing on this issue. One of the areas that is going to have to get further review is in Colorado Springs, Colorado. And there are 3 anonymous whistleblowers who have come forward and said that there are problems with manipulating waiting times. And I've talked to the leadership in both Denver and Colorado Springs. They have told me personally that this is not going on, and I believe them, but at the same time, we have whistleblowers saying that it is going on. Mr. Matkovsky, how does the VA treat whistleblowers? And what I'm getting at is there is intimidation taking place. How do we change the culture from intimidation to where people are free to step forward?
Part of how we designed this audit was to have direct access to the front line from our senior staff. When our auditors went to the field, they met at the same time with union representation at the field and the facility management. Not 2 separate meetings, 1 meeting. We did not provide advance announcement of who we wanted to interview. We provided that when we showed up so that we could have a direct conversation. I will tell you, I have read through the open-ended comments of all of the responses that I could, and nothing saddened me more than an employee who says, I was trying to do it right, I know it is right, and I received instruction to do it wrong. That is just simply not tolerable. Retaliation against whistleblowers is also not tolerable. We cannot condone that. We require a leadership and cultural shift in our way of managing.
And I raised this a couple weeks ago at our last late night hearing, and that is, if you can't rely on the data, if you can't rely on the records, because secret waiting lists by their nature are meant to conceal the truth from someone who's doing a review, like yourselves, is the alternative to go in and do a case-by-case analysis, talking to every single veteran who tried to get an appointment and doing this on a one-by-one, even if that takes hundreds or thousands of contacts? How do we get to the bottom of it when the records or the reports are not reliable?
I believe we have to begin with the end in mind. If what we want to do is to provide veterans with timely, quality health care, let's ask them, how are we doing? How's our care? How's our access? Is our access meeting your requirements? Is it not? If not, let's fix it. The thing that's terrible about this crisis is this isn't even an output measure, right? It's an activity measure. And what happens when we change that activity measure is we can't tell where we're not timely. If we can't tell where in no cases were we finding frontline staff who were delaying care by moving the appointment later in the calendar. They were changing the reference point. When that happens, we don't know where we're late. When we don't know where we're late, we can't identify where we need resources or to realign resources. And when we don't know that, our entire system of requesting for resources is thrown off.
And Ms. Metkovsky, I hope we've seen the final days and never again where bonuses or promotions are based on metrics that can be manipulated, instead of, like you mentioned, and I've mentioned this before, and others have also, outcomes like patient satisfaction or good care that can be documented, not metrics that can be manipulated.
I concur.
And do either of you other two folks want to comment on that issue? Mr. Griffin?
I think it comes down to accountability of the senior leadership out at these facilities. And once someone loses his job or gets criminally charged for doing this, it will no longer be a game, and that will be the shot heard around the system.
Thank you. I yield back.
Ms. Brown, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, thank you for having this hearing. And colleagues, I want to make sure that we're firing at the right target here tonight. We're all on this committee because we care about the veterans. And you can be sure the only reason why I'm on this committee is I care about the veterans, and I've been on this committee for 22 years. And so I have a couple of questions. Dr. Draper, you mentioned, and I want to thank you for your service, but the case that you gave about outsourcing that particular case, and it wasn't the right kind of coordination. Can you expound on that a little bit more? Because a lot of people want to see us partner with veterans if they can't get the service right away.
Yeah, I think it's an important point because, you know, there is a lot of talk of sending more veterans out to the community for care. And while that is a way to expand capacity, as I mentioned, there are some pitfalls because VA does need to do a better job of monitoring wait times, managing the coordination, and just making sure that the veteran actually receives the care that they're going out to the community for. And that was why we illustrated this particular case, because this was, you know, at many points, you know, that did not happen, and you know, the veteran waited a long time and ultimately died waiting for care.
I have a question about the survey, because a lot of veterans tell me in a lot of discussions, once they get into the system, they think the system is the best. No complaints about once they get in. Can you, both of you, can you expound upon that? And a lot of the specialties that is involved in the VA is not necessarily out in the community. I mean, we're at the cutting edge as far as different kinds of technology working with their unique ailment.
I would say in my experience and reviewing various VA facilities, I think there is variation among facilities. There are some that are very, very good and some that are more problematic. So I think it's not consistent across all VA facilities, the quality of care.
Congresswoman Brown, I think we have a good system. It is not the best it can be. The system belongs to veterans and their families. We are a system that is designed to understand their needs, to work for them. And on the front line, you find our staff are so engaged. I think their passion is unequaled.
What percentage of the staff are veterans that work at the VA?
Over 1/3 of our staff are veterans themselves. It's a matter of making sure, however, that we have integrity in the system so that we can identify where access is not working. It's not okay anymore, with all due respect, to say it's great care when you can get it. It must be that it is great care and you can get it.
Timely. I guess that's the key. Mr. Griffin, any comments about one of the problems, it seems, is that a lot of the equipment, the technology that the veterans have is outdated. You know, the computer systems and the different systems. Could that affect part of the scheduling problems that we're identifying?
Absolutely. Going back to 2005 on the audits that we've done, one of the recommendations has been that they needed to have an automated capability to review wait times remotely. A lot of money has been wasted, millions of dollars have been wasted on contractors trying to create a better system for capturing this data. And over the past 15 years, going back to 2000, it hasn't had any success.
If I may, Congresswoman Brown, I think it's important to understand that our scheduling system scheduled its first appointment in April of 1985. It has not changed in any appreciable manner since that date.
What about the equipment that I'm asking you about, the technology? I mean, we've had lots of meetings about technology, even people coming into the system. You know, we brought in the banking community to make sure that people can't go in and, what do they call it, steal your identity? So, I mean, that's part of the system also, right? Is that correct?
It is. So we have, some systems are evolving and are improving. We have a new Veterans Health Identification Card, which has removed the Social Security number from the barcode and the magnetic stripe. That has been a good change. But I think across the board, if you look at our engineering systems, our facilities management systems, our building systems, our scheduling systems, our administrative systems, these are old systems that in many cases date 20 and 30 years ago, before the internet. I was still in college. You know, these are old systems.
Yes, sir. Well, thank you all for your service, and I'm looking forward to round 2.
Thank you very much, Ms. Brown. Mr. Middlerakis, you're recognized for 5
Thank you, Mr. Chairman. Again, thank you for holding the hearing. I will have a question, and I know, I want to follow up on Mr. Michaud's question. This is for Mr. Makowski. As Mr. Michaud said, in GAO's testimony, it was stated there are no detailed system-wide VHA policies on how to handle patient no-shows and cancellations. Are you aware of any department-wide policy for cancellations? Mr. Makowski?
We do actually have, in our directive, we do actually have policies for managing no-shows and cancellations. And we also have a policy that is supposed to guide our staff on how to manage veteran appointments and communicate with veterans and their families to minimize the chance.
Well, describe that policy briefly. I don't have a lot of time, but.
Okay, so for instance, if we have a veteran who has once not shown up for an appointment before or has repeatedly not shown up for an appointment before, we have a no-show list that allows us to contact veterans, and that's actually part of our policy. and sites are supposed to be implementing it. We need to do a better job of training, following up, and ensuring that that practice is performed.
Well, I agree with that. I hear about the long wait times. I had a town meeting last week, but I meet with veterans frequently. 3-hour town meeting, and one of the complaints, of course, was the wait times. Everybody knows about that. Missed appointments. For example, the veteran gets the appointment finally, and maybe through no fault of their own, they can't make the appointment. Maybe an illness, or maybe somebody just forgot, and then they have to wait another 2 months, for example, for an appointment. Let me ask you this question, because that's a huge problem. Is there any input? I mean, I hear about the lack of communication between, let's say, the schedulers. You can call over and over and over again. Does the veteran have an input on when that appointment might be? You know, for example, they could have a conflict, a family conflict, medical conflict, what have you.
Could I answer that?
Yeah, because that was an issue with the case that you cited.
It is, and part of the problem is, and I wanted to elaborate a little bit more on the no-shows. I mean, part of the issue is that VA needs to better understand why the no-shows and cancellations are happening, and part of it is, as we found in our wait times work, that some schedulers, a pretty good percentage of schedulers are engaged in what is termed blind scheduling. So they schedule appointments without being in contact with the veteran. The veteran receives the appointment through the mail, and sometimes it may not be convenient, or it could be that the appointment was the letter was received after the appointment actually was scheduled. And then we also see that you know, sometimes the VA contact information is bad, so the veteran may never receive that that appointment notice. So there's a lot of factors that go into the no-show and cancellations, but that is a part of one of the factors that also affects that.
Have you ever asked the question of the veteran, how would he or she prefer to get this information with regard to appointments?
We need to improve the ways that veterans can see their appointments, manage their appointments, and frankly ask for appointments. We need to make that an integral part of our online system for My Healthy Vet. We do have a patient self-scheduling application, which we are trying to roll into a state of production. But frankly, it just starts with the phones. You know, pick up the phone, call repeatedly, and talk to a veteran and find out their preference, and then schedule.
Thank you. And again, the My Healthy Vets, it's a great thing to have, but again, that should be in addition to the personal contact. And of course, a lot of, some people don't have access to a computer either. So let me ask you one more question. I know I don't have a lot of time. Again, with regard to the wait list. In the hearing this committee held on May 28th, 2014, members of this committee repeatedly, and I know I asked, who authorized the destruction of the interim electronic wait list? However, Dr. Lynch maintained that it was protocol for when the appointments were canceled. If there is no department-wide process for no-shows or cancellation, now you stated there is, but what was he referring to?
I don't know specifically. I've not been on the ground in Phoenix myself. I do know that one of the things they were working on was to try to move appointments sooner. And what they may have been doing, which he referenced, I believe, in his comments, was printing, rescheduling, and then shredding the evidence because it contains personally identifiable information. I think that's what he referenced, sir.
All right. We'll continue to ask the questions. Thank you very much. Now yield back.
Thank you, Mr. Bilirakis. Mr. Takano, you're recognized for 5 minutes.
Thank you, Mr. Chairman. For Mr. Griffin or Mr. Matkowski, in your investigations and audits, did you identify any sort of pattern when looking at wait times and scheduling practices? And what I mean by this is, are there some types of facilities better or worse than others? Are wait times longer for certain types of care? Primary care versus certain specialty care, for instance?
I would say one of the principal methodologies that we have witnessed is a veteran calling in for an appointment. He gets an appointment 120 days out because that's the first available appointment at that facility. and then that appointment gets scored as the desired date of the veteran, and therefore 0 waiting days. The vast majority of the cases that we have seen involve that scenario. The other scenario would be you get that appointment 120 days out. 2 weeks before the appointment, it gets canceled in the system, and then it gets recreated. Veterans no wiser for the fact that his appointment was canceled because it's recreated for the same time and date, but once again, it reflects a waiting time which does not reflect the reality of the amount of time that veteran's been waiting for care.
Those are similar to what we found as well. I would say in terms of the wait time data for new veterans, we tend to be able to trust that data better because it has a computer date stamp in it. It's not perfect, but it's better. We do find specialty care has longer waits among those veterans. And then we also note wait times in primary care.
Thank you. That was a very clear illustration of some of the pattern. Can you tell me, so in Phoenix, there is both wait times of this nature for both primary and specialty care? I mean, I saw that the primary care numbers were...
We did see a significant count for primary care. There are a number of veterans on the electronic wait list waiting for primary care appointments. What will typically happen is that you will then see a subsequent demand for specialty care. So as we're bringing in resources for primary care, we're also very cognizant of the fact that we're going to require to address specialty care in Phoenix, sir.
Well, I don't want, in my question, I don't want to excuse at all the manipulation of wait times. So that's not the point of my questioning. But I want to ask you if, from your data and your audits, are able to comment on whether there's an underlying shortage of providers. You mentioned a scarcity of appointment slots. How much is that attributable to a shortage of providers? And how much is that attributable to maybe inefficiencies in the way the facilities operate?
I think we have to check them both. I think that in some cases we have provider shortages, but I think frankly we owe it to American taxpayers to run an efficient system as well. So we have to look at productivity data and we have to look at the amount of time in clinic serving veterans. But I think it's both.
Ms. Griffin?
If I may, I think an integrated health system is the best system for veterans who have multiple conditions that they need care for. The further you dilute the locations where that care is provided, the greater chance of the care not getting properly reflected back in the medical record, the greater chance that that particular provider for that one instance of fee care may or may not be fully aware of all the other conditions that that veteran is facing. So I think what it's about is the business process of return on investment for getting your own doctors who are committed to the VA mission, who are full-time employees at VA, as opposed to the $4.8 billion in FY13 that was spent for fee care. I think there just has to be a strategic analysis of what in the long run is going to be the best outcome for veterans. And it's something that has to be continual because you'll have different mix of conditions from one facility to the next.
Along those lines of the integrated care question, is there a pattern in your research to the quality of care related to whether or not a VA facility is affiliated with a university hospital?
Oh, I don't think so. I mean, I think our affiliate hospitals tend to be the more complex hospitals and will have a more complex set of services available to veterans. But we have some of our highly rural, unaffiliated hospitals that also wind up being top performers in the healthcare industry rankings.
All right, thank you. My time is up.
Thank you very much, Mr. Cano. Dr. Rowe, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Last week during the recess, I had an opportunity to do something that was very personal to me. As a Vietnam-era veteran, I went to Vietnam, and we talked to the folks there that were looking for our 1,200 MIAs. And quite frankly, I think we owe it to the honor of those who didn't return to provide for those who did. And we're not doing a very good job of that right now. And one of the things that I think the problem with the VA system is that the financial incentives are lined up to not provide the care. Let me give you an example. In no-shows, for instance, when that's a problem with a consult, in our office, and we had patients who were supposed to come in as a consult, not a regularly scheduled patient, we had ways to check for those folks, because if they didn't show up, they took up a slot that we couldn't fill with somebody else. There is no penalty when somebody does that to VA. That's just free time. And I'll give you an example. I'm looking here at a medical center that saw 68,796 patients. That was an entire medical center. Our practice of 10 doctors saw 40,000 patient visits in a year. So I think part of it is, as Mr. Mikowski, you said, is productivity. It's the incentives to make sure that when you have a consult on there, you consult that. As Mr. Bilirakis just said, I don't just put a patient on my list when I'm seeing a patient in my office and say, show up. I found out, is it convenient with you, the babysitter? Maybe my wife is sick. There are lots of reasons, and you can call a person. There is a thing called a telephone. You can pick up and call somebody. And Mr. Jones, are you going to be able to keep your appointment next week at 10 o'clock? Those are simple things. It doesn't require computers. It requires just a human being and a personal touch to check with that person. I can tell you they appreciate it. The patients appreciate it, and they will keep their appointments if you do that. When you make something for me in September, I may forget about it, but then I have 10 other things to do. And I think that's part of the problem right there. Again, the financial incentives and then just making them so far out. And I guess a question, Dr. Draper, I have for you. Did you all notice any particular kind of consultant? Because I think, there are areas, for instance, maybe in cardiology you have enough, but rheumatology, maybe neurology, those are very difficult positions to fill anywhere. Did you notice a difference in the type of consult?
Well, we looked at three specialty areas: gastroenterology, physical therapy, and cardiology. And we heard from the VA Medical Center officials, particularly in the areas of physical therapy and gastroenterology, that there was an increase. The demand did not keep pace with the number of providers that they had. So, the demand kept increasing, and they really didn't have the providers to always take care of the patients or fill the slots.
So it did matter which type. I thought it probably did.
Yeah, and we didn't look at all specialties, but those were the three that we did look at.
Okay. Mr. Mikowski, one question I had. How much is your pay for performance? I asked this last week or week before last. When you're evaluated as a senior person at the VA, is your pay for performance related to how many veterans are sent out in the private sector, along with the wait times? Is that part of it? No one could give me an answer.
I don't believe it is, sir.
Okay, that's fine. If it's not, it's not.
Right.
Also, Mr. Griffin, for me personally, I know the chairman asked this question about the potential, when you have put a system in place that fraudulently puts information out there, and then you gain financially from the taxpayers, that would seem to me to be a fraudulent case. I'm just simply looking at it as I'm not a lawyer, I'm just simply looking at it as a layman. When you've gone out there and on purpose misled, knowing that you would get a financial bonus if you did that, which is exactly what's happened, is that fraud? I think it is.
I agree. The issue is you start with the GS5, GS6 schedulers who have many, many layers above them before you get to the top leadership of the facility. So you have to work your way back up the supervisory chain to determine who put that order out to do it in this manner. And that's what we're having to do at 69 facilities other than Phoenix right now, with additional facilities reporting in every day. So it's not an easy task. I suspect if people do start getting charged, maybe that middle-level person will say, wait a minute, I'm not going to take a fall here for somebody higher up the food chain than me who directed that we do this.
Yeah, I certainly don't want to see a scheduler making somebody's appointments head roll and nobody. That's not right. Okay, I yield back, Mr.
Absolutely.
Thank you, Dr. Rowe. Ms. Brownlee, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you again for your leadership on this committee. My first question is to Mr. Makowski. I understand that the acting secretary has sent a triage team to Phoenix, as you testified, which I wholeheartedly concur with. But after reviewing today's audit numbers and some of that data, it's clear that there are other medical centers across our country who are experiencing similar or even worse wait times. Greater Los Angeles is a good example of that, whose wait times exceed the wait times in Phoenix. So my question is really about, okay, a triage in Phoenix is good. We need triage elsewhere. What's the plan? When are we going to get to that?
I believe we need two things, by the way. Thank you, Congresswoman Brownlee, but two things. First, we need to reset how we measure so that we know where we are performing well and where we are not with confidence. As part of accelerating care, we looked at wait times that we could assess. We requested medical centers to survey their capacity. We broke it down by clinic, by medical center. We use something called stop codes. So cardiology would be a stop code, GI would be a stop code, and we have individual wait times for each of those. We were also able to produce the productivity numbers for each one of those clinics and ask if they had low productivity and wait times to address the productivity concerns. There are a couple of ways you could do that. I think I'd mentioned them. Run a few more clinics per week. Run some evening, run some weekends. And then if you could not find capacity, if you were at capacity, request the resources. If you don't have it and you need it, ask for it. Part of our job as well is to make sure that our staff at all levels can raise the flag. So system-wide, that is what we have done. I think we have at this point identified an additional requirement for $300 million, the vast majority of it to support the acquisition of healthcare now. And I think those funds are dropping tomorrow morning to the field.
So can you just tell me as a follow-up how you're going to prioritize that? Is there a schedule for that?
Yes.
My veterans in Ventura County, the West LA facility is their primary medical facility. I would certainly, this data is now public as it should be, but the first question my veteran community is going to be asking is when?
Tomorrow, and beginning on May 23rd, each medical center with wait times for veterans was directed to contact veterans after they could determine if we could have additional clinic capacity, if we could not have clinical capacity, and we could acquire care in the community. One of the things we have to be careful about is that there's not an infinite supply of primary specialty or mental health care in the community, right? So if we can find the quality health care to purchase in the community, coordinate that care, the next step is to pick up the phone, call a veteran and ask them when they want to be seen. As of Friday evening, I believe we had made 50,000 phone calls in the facilities and networks across the country. We want to finish those phone calls, and then we want to move on to the next set of phone calls, working back from wait times as we get closer and closer to what we think is timely care. But that has already started, and we'll be tracking, I think, beginning this week, the rate of obligations of those funds. So we created specific account codes for the funds, and then we'll be tracking in the non-VA care the use of those funds to accelerate care.
And that data you will be sharing with us?
I will share that, yes.
Thank you. And you mentioned about, my colleague here also mentioned about having enough personnel and professionals in the system as well to meet the needs. And I know that the acting secretary also has ordered a hiring freeze across the VA. And so I want to know what that means, and because it seems to me, we have to, fix this airplane while it's flying, right. And it seems to me that we should be looking at our hiring practices and hiring, as well as addressing some of these other issues that have been broken within the VA.
I think we need to look at the time that it takes to hire staff, to recruit, hire, onboard, and credential our staff. I think we have to look at that. But the acting secretary's point here is not to restrict us from hiring staff in the field. It is to request that at our network offices and in headquarters, we have a hiring freeze. And the point behind that is so that we can dedicate our HR resources to hire for the field. At some point in time, we may lift that when our HR machine is working and we're able to staff for vacancies where we identify them. But we can't be satisfied with having a vacancy and then initiating the recruitment process and allow that to take 6 months. That means we're running at under capacity for 6 months in that specialty. We have to change it. We have to hire to budget, make sure that we don't hire or have a conservative resource committee locally that prevents us from having the clinical resources we have when we set our FTE requirement. The acting secretary is not telling us, do not hire in the field. What he is telling us is focus.
Thank you. I yield back, Mr. Chairman.
Thank you, Mr. Brownlee. Mr. Flores, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I also thank the witnesses for testifying today. Mr. Makowski, in your testimony, you referred to something, I think you said high-performance facilities. Is that correct?
High-performing facilities, yes, sir.
High-performing facilities. How many of those are in the VHA system, and roughly where are they?
Well, we found them in different ways, sir. So we found facilities that have a good handle on access, patient satisfaction. I think the acting secretary came back from his visit to San Antonio. And the passion, the mission, the drive, the energy is palpable in some of our facilities. I will tell you that in some cases, entire networks, we did not find facilities that had integrity issues worth us reviewing. And in some networks, we only had selected instances. So both from an integrity perspective and from a veteran-focused perspective, we have high performers who get the process right. Schedule with integrity, report your wait times with accuracy, find resources where you need them, and we have a number of them.
So we have these high-performing facilities that have much better outcomes than the other facilities. What is it that makes it different?
Culture and leadership, sir.
Okay, it's the leadership of the facilities. I'm going to move to Dr. Draper. In your reviews of the VHA, did you find similar high-performing facilities like Mr. Bukowski referenced?
As I mentioned, we see variation in facilities. I think there are some really excellent facilities and some that seem to struggle.
Okay.
And I would agree that, part of it is the leadership issue.
And Mr. Griffin, did you find similarly find high-performance facilities or teams?
If I could expand a little bit, we have done a couple of reviews of the VISN networks, and we concluded that if you've seen one VISN, you've seen one VISN. It seems like if you have high-performing facilities, whether at the network level or the medical center level, you need to export those best practices around the system. There have been issues in the past where a problem has been identified, and you send it out to the medical centers, and in many instances, top leadership in VHA sent out safety alerts and directives and what have you, and they weren't followed.
Okay.
So you've got an accountability issue there, you've got an integrity issue there, but there ought to be a best model for similar sized medical centers so that when a directive goes out, you know, okay, at this facility or at all the facilities, the chief of staff owns this issue, or the chief of surgery, or one individual. But some of our reports, like on reusable medical equipment not being properly sanitized after use, there was no one person at every facility who had ownership of that issue. So, you reap what you sow. And when you send it out there and there's no consistency in ownership, then the results are predictable.
Mm-hmm. And so do you concur with the other two observations that it's the leadership of those facilities that sets them apart from?
I think it's leadership in the field. It's also leadership in headquarters.
Right. Okay. And Mr. Griffin, the interim report cited the need to minimize the chances of evidence destruction, data manipulation, and coaching employees on how to respond to the OIG questions. Do you have any evidence that any of those activities took place, the evidence destruction, data manipulation, or coaching employees?
There's plenty of evidence of data manipulation. Okay. The question of destruction, we had a contact from a Hill staffer the first weekend in May reporting that they had heard there were parties going on destroying documents at medical centers. We responded to 50 medical centers that weekend and didn't find any destruction that we came upon in those unannounced visits.
How about coaching employees on how to respond to the questions of your team?
Our team's questions are not similar to the questions that they were posed by the audit staff that VHA sent out there. All of our interviews were taped interviews. People were put under oath, and we asked them straight up, who told you to do this? Some produced emails. Some said, well, we've always done it this way. The range of answers is what caused us to identify it as systemic, along with all of our previous audits.
And one last quick question. Did you run across any employees that said they would be willing to cooperate, but they weren't because they were concerned about reprisal?
We had anecdotal reports of reprisal occurring around the system.
Okay. Thank you. I yield back.
Thank you, Mr. Flores. Ms. Titus, you're recognized for 5 minutes. Microphone, Ms. Titus.
In May, the VA launched the Accelerating Access to Care initiative, and this program was highlighted in your press release today. We've all talked about, we know that the goal of this is to help veterans who've been waiting for a long time get access to care in the private sector. Now, I support these principles. I think that's a good idea. But as you've heard kind of referenced here, the U.S. is facing a significant physician shortage nationally, and not just in the VA, but in the private sector. For example, in Nevada, we have a chronic shortage of doctors, both in primary care and among specialists. Just the statistics, we're 46th in the nation for general and family practitioners, 50th for psychiatrists, 51st for general surgeons. So as a result, it's not only the veterans in Las Vegas who have these long wait times, everybody is affected. Now, there seems to be this big emphasis on getting into the private structure to get care, and that will solve the problems. But I wonder what you're planning to do to ensure that veterans receive care in the private sector in communities like in Nevada, where the issue of physician shortage and waiting times is not just limited to the VA facilities, but is out there in the community.
Unfortunately, Congresswoman, I do not have an easy answer for that. There are things that maybe we can explore on how we can attract clinical talent to Las Vegas that might help us as well. I know that even in the Las Vegas campus, we had at times talked about creating a medical school hub that would help us attract talent. We have found that that works, by the way. One of the benefits we have in terms of having our affiliate partnerships is the ability to attract talent. Roughly 70% of America's doctors have received some of their training from the VA. One of the things that allows us to do is attract young talent that frankly falls in love with our mission and comes to work for us. So I think that we do need some help, but we need broader help than just contracting or just VA, and we need to explore other solutions. And I think Las Vegas is one of those areas.
Well, we have the University of Nevada Medical School. We have Thoreau there. We have this big new hospital. What about the increase in residencies and some kind of partnership?
Absolutely. So I think we need to look for that. Yes, ma'am.
One other question is, if money were to become available now, like we've heard about on the Senate side, to hire more doctors and to build more facilities, are you ready for that? Do you have a list of priorities? What are those priorities? And what kind of metrics or planning are you using to make those determinations?
We have a significant, as I think this committee is aware, we have a significant construction requirement both to maintain our facilities, which I believe are roughly on average 60 years old. They are landlocked facilities. As a matter of fact, in Phoenix, I know we're talking about Las Vegas, but in Phoenix, we had to bring down mobile clinics to handle the extra staff. Space matters. We need space. So we do have a list of priorities where we require space, whether in the form of leases, in the form of minor constructions, or frankly, major constructions and overhauls, or just refurbishing our aged infrastructure. And we clearly have an identified need for providers. Over the next 30 days, however, we're going to take a much closer look at our current productivity and where we find demand and our inability to meet it.
Well, I know when the new hospital opened in Las Vegas, before it even got started, the emergency room was determined to be too small because the demand on the hospital was much greater than anticipated. I think usually it's about 2%. In Las Vegas, it increased by 19%. So I just want to be sure that as you look at your priorities, you include in those plans some demographic calculations for growth in the need for service, because once it's there, you build it and they will come. Okay, thank you. I yield back, Mr. Chairman.
Thank you, Mr. Titus. Mr. Denham, you're recognized now for 5 minutes.
Thank you, Mr. Chairman. Mr. Matovsky, is this the audit that came from the VA?
Yes, it is.
I noticed in here that on the 14th of May, Livermore, which is in our contract area, was audited. Now, I sent a letter in over a month ago asking the VA, requesting that each of our districts, we be given the information, whether that's a private briefing or whether we get public information. But I think every member of this committee has a right to know what's happening in their own districts. Is there a reason we don't have that information yet?
The only reason we didn't prepare it, sir, is that we were completing phase 1 and phase 2. One of the concerns we had in some of our very small CBOCs, there aren't a lot of respondents, so there aren't a lot of staff. We guaranteed our frontline staff anonymity, and we wanted to preserve that. So in as much as we can, we want to make sure that we roll the data up to the parent facility, sir. But I will be happy to organize briefings or any similar mechanism to provide the information.
So there's no reason that we shouldn't receive that information very soon?
No reason. The only concern, once again, that I would have is in our very small clinics where there are just a small number of folks who we interviewed. I want to preserve their anonymity. These were frontline staff members, and we made that promise to them when we did our interviews.
You say in this report some locations were flagged for further review and investigation, for instance, of suspected willful misconduct. Where misconduct is confirmed, appropriate personnel actions will promptly be pursued. Livermore VAMC in California is on that list.
That's correct.
So at a certain point, I assume you're going back into that facility to get further information.
We will. The Office of the Inspector General and I and others will actually be meeting this week. We're working on a plan to make sure we coordinate those reviews. We do not want to impede an investigation, but we will.
Appropriate personnel actions will promptly be pursued. What type of personnel actions will be pursued?
Commensurate with the nature of the problems we identify.
Firing?
If required, yes.
I just recently went to Palo Alto. I took a group of local veteran leaders throughout my district to Palo Alto, and I will tell you, we saw some very dedicated doctors. We saw some very dedicated staff, but we also saw some big glaring challenges that they recognized were big challenges. Now, we've heard in this committee many times now that the VISTA system is state-of-the-art. Do you think it's state-of-the-art?
I can speak for my domain, sir. I'm administrative. I am in the finance domain and the business applications and engineering. I can tell you that for engineering, it is not state-of-the-art. For our work order management, for our biomed technicians, it is not state-of-the-art. For our facilities management staff, it is not state-of-the-art. For our housekeeping and environmental management staff, it is not. For our billing,
what is it state-of-the-art as?
I believe that in the electronic health record, as an integrated health record that captures all documentation associated with a patient and enables the collaboration and the delivery of that care, it set the standard. In some of these other domains, I think we need to look to industry to find other solutions.
And you're doing scheduling under that same system?
I put scheduling square in front of that same question. I think we need to look to the industry that knows how to deliver systems and acquire.
So if all of those areas are lacking, why is this not part of the VA action plan?
The scheduling package is a part of our action plan, sir. So one of the immediate things that we need to do, we are working with OINT. We plan to have an award before the end of this fiscal year for a replacement scheduling system. Our intention is not to pick someone who can write for us a book about how they're going to develop a scheduling system, but rather to acquire a scheduling system and then deploy that scheduling system.
And one final question. Another thing that I noticed there, obviously you've seen how this committee as well as the House feels about the firing process. We think that we need to help you through that process and give you the tools to implement that type of discipline. But one of the things that I also saw was that the staffing system was flawed. I mean, if it's taking you 3 to 6 months to hire a doctor that is ready to be hired, you're going to lose them to the private industry every time.
I'm not an HR professional, but I would agree. We need to work on our speed.
I yield back.
Thank you, Mr. Denham. Ms. Kirkpatrick, you're recognized for 5 minutes.
Mr. Mikowski, I'm encouraged by the fact that you're looking to industry to help solve this problem. I actually sent a letter to the President last week recommending that that be done, because we know that there are organizations that do massive scheduling and they do it right and they do it well, and we want that to be available to our veterans. So thank you for that. My first question actually is to you, Dr. Draper, but I'd like the whole panel to address this if they could. I represent a very, very large rural district in Arizona, and my veterans get care at 4 facilities: Albuquerque, Prescott, Phoenix, and Tucson. And Dr. Draper, you said that there is not consistency among the various centers. And I wondered if you could identify for our committee the top 3 reasons for that inconsistency, and then what we can do to make sure that this is the best healthcare delivery system possible for our veterans.
Well, part of it is as I talked about in my oral comments, the weak and ambiguous policies. And one example, I'll go back to the wait times and I mean, not the wait times, the canceled appointments and no-shows. And there is a VA policy. It's very ambiguous. So what you find is there's each facility develops their own policy. So we've seen anything from a 1-1-30 rule in one facility where they have one phone call, 1 letter, and they give the veteran 30 days to respond, or the consult is canceled. We've seen anything from like 2 canceled appointments, and then it's canceled. So these things play out at. There's a lot of variation at the local level, and the key point with the consults information is VA is trying to put together a system-wide database of consults. So if you have these local policies that vary, then what your data is going to reflect, it's going to reflect variation. So you're really not going to be able to compare apples to apples. So that's one example, and we see similar things such as that.
Mr. Mikowski, can you address that question?
Well, I would agree with Dr. Draper. I think one of the things that our policy does, it sets about the operating principles, but we need to tie a handbook to that or standard operating procedures that provide precise instruction so that there's not an interpretation. If we have a contact policy, this is how you do it. If we have a scheduling policy, you are to contact the veteran and work with them to schedule the appointment. What do we mean by contact? We need to spell that out. Either 3 or 4 telephonic attempts spread over the day as follows, followed up by a letter or something like that. We do need to do a better job and spell it out in our policies so that the rules are standardized.
Is there a structural problem in the administration at the Veterans Affairs Office? I mean, it just appears that it's just all over the place, and I'm just wondering if there needs to be a total reorganization of the VA system in terms of oversight, supervision, accountability, and transparency.
I think we just need to get back to our core of delivering safe, quality health care to veterans that they expect and that they have earned, and start with that in mind. Understand how we want to do that, define the practices in policy, promulgate that policy. Don't allow us to have a separate policy that can interpret a different set of rules from a national policy. We write a national policy, publish it, and hold people to it.
I just have a feeling the problem goes beyond that. Maybe, Mr. Griffin, you can address it, because you said that the technology is outdated. It goes back to 1985. I guess I have to wonder why. I mean, this committee wants to get this right. We've got to get to the bottom of this, but why are we still using 1985 technology? Is it a lack of funds? Is it a procurement
I would approach it from a different angle.
Okay, good. Go ahead.
Your facility's only as good as the people working there. And basically, there are 5 qualities to every great team. Communication, upward, downward, and lateral communication. Managers need to get out of their office and walk around the facility and find out what's going on there. Second thing is collective responsibility. Everybody on that team has ownership of the outcomes there. Pride. Be proud of helping our nation's veterans. Be proud to go to work every day to help our nation's veterans. Caring. Of course, in a medical center, caring has got to be one of those qualities. And trust. And if you have those 5 qualities, you're going to have a great team. And I think that's what needs to be instilled in the personnel at all the facilities.
Thank you. I'm running out of time, but it sounds like, Mr. Chairman, that policy and personnel are 2 key issues in getting to the root of this problem, and I yield back.
If I can, real quick, and I apologize, Mr. Runyon, but I kind of want to bring the committee up to speed because there is a very important question that needs to be answered. Why are we still using outdated scheduling software and programs? VA has requested and Congress has funded IT enhancements to include a new scheduling system, which has been dubbed a failure by GAO. The scheduling replacement project was $127 million over 9 years, and it was hindered by management weaknesses. Then we had other issues, VA scheduling replacement project, which is what I just talked about. Then there was a $249 million used for core FLS. Its follow-on was flight, $607 million. And then there's the Vista FM, $2.4 billion in investments that this Congress has made, and yet we sit here asking, what is the answer to the question, why are we still using outdated systems when we have given hundreds of millions of dollars to the VA? Mr. Runyon, thank you. I apologize. You're recognized for 5 minutes.
Thank you, Mr. Chairman. And first of all, I want to associate myself with the comments that my colleague, Mr. Denham, made. 2 of the visits that my veterans visit, number 4, number 3, 3 of the facilities, the Lyons facility, the Philadelphia facility, and the Wilmington facility, are all in that further review category, and I request the same information that Mr. Denham did. I have for purpose of, I think, why all this started, and the secret lists, so we say, as a simplistic question, is Vista not capable of scheduling 2 years out? And if we didn't have the metrics that Dr. Lynch sat here numerous times a couple of weeks ago and said, these metrics are forcing us to play these games, is that a possibility?
I think it is part of it. I think that they go hand in hand. But first of all, I think setting an unrealistic performance metric and tying rewards or incentives to the meeting, again, this isn't even an outcome measure, right? This is an activity measure. Tying rewards or incentives to the attainment of an activity was a mistake. Not understanding the capacity of our system when we set that was a mistake. There are reasons why we don't schedule 2 years in advance, quite frankly. You don't want to hold up the entire set of appointment slots with appointments that are so far out that they might end up getting missed. I mean, there are technical reasons why you wouldn't do that. But for the most part, this is a leadership and culture question. We have found in some of our networks where staff are using the same outmoded technology as other staff, using the same policy, and can schedule with integrity.
I bring that up because I think you kind of touched on it there. There's a balance there. And what is it? And I think it's going to go to my next question, and I think several people have brought it up. Standardized procedures and policies from Washington. I mean, you've seen it, you know, the different visits, the wait time issues, and it goes to this question that I asked last time, and I, believe it or not, got a response this afternoon. I asked a question about a auditing feature that was turned off in the Phoenix region there, and got a response that it had been turned on nationally. Could any of those audit features been turned on helped the IG in the process and or internally in that region for them to avoid these situations?
Sure. I think the one thing that I would clear up is that audit is audit logging inside Vista that sort of records who edited what and captures those edits was never turned on anywhere. The concern was that it would affect system performance and it would create a huge data storage requirement, so it was never turned on. That is now turned on across the board. That'll help us understand who edited what kind of appointment. So for instance, I think the one comment was made how you would cancel an appointment. We could see who did that, and if that occurred numerous times, we could marry that up and find that behavior. Who edited what kind of field at what time helps.
And I just want to make this statement because I'm sure, as Chairman just said, there were millions of dollars spent for that feature in the initial outroll of that system.
I would say the one thing that we're going to do different with this acquisition is that it's not going to be just a proposal. Part of what we're going to expect folks to give us is working software that is proven to integrate with our system. Not a book about how that software some point in the future will integrate, but a working product. That's part of the proposal.
Thank you. Chairman, I yield back.
Thank you, Mr. Runyon. Dr. Ruiz, you're recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this hearing. With the release of the Department of the VA Access Audit and the Interim Inspector General's report, it is clear there is a systemic failure of responsibilities, widespread misconduct and cover-ups that led to the deficiencies in scheduling, resulting in lengthy wait times and veterans dying waiting for care. The veterans in my district and across our nation deserve better. I demand that the new leadership of the VA put an immediate and decisive end to this severe misconduct and hold those responsible accountable for their actions. As I've called in the past, and which we have discussed today, a criminal investigation is needed to remove individuals who knowingly prevented veterans from receiving the timely and quality health care they needed and resulted in harm or death. A criminal investigation will put an end to this wrongdoing, will change culture and now and for the future. Currently, there are over 1,500 veterans that utilize the Loma Linda healthcare system, many of which live in my district, that are either waiting over 90 days or going without an appointment altogether. It's time that the House pass the Veterans Access to Care Act, H.R. 4810, to make it easier for veterans who are too far from a VA or waiting too long for an appointment to seek care outside of the VA system. As a physician, I will continue to work as a member of this committee to, 1, stop the scheduling misconduct, and 2, treat the veterans, give them the care when they need it. And after reading the audit today, I had several questions. The first are, what are the possible solutions to get veterans triaged and cared for immediately or sooner than anticipated? Now, let me preface this, that there are other veterans with aneurysms, perhaps, that need care now. There are other veterans with suicidal ideation that need care now. There are other veterans that have cancer that are on the verge of spreading that need care now. We must hold the individuals accountable. Yes, we do and we will, but we need to give care now to our veterans. When I was in Haiti, working in a disaster zone with the 82nd Airborne, there were immediate striker teams formed that would go out, educate the population of do the research, educate the population of the healthcare available, form teams, go out there and treat the patients. What are we doing to treat our veterans now?
On May 23rd, we asked all of our facilities, we provided them their productivity data, and we asked them to assess if they could get more productivity out. We also gave them their local weight data, computed nationally and distributed to the field. The instruction was clear. Where you can find capacity now, overtime, extra clinic slots, you name it, find it in the system. This system belongs to veterans. We have to make it efficient. That's the first order of business. The second order is then, if we cannot identify where we can acquire that care in the community, beginning May 23rd, contacts were going out to the field. One network, Network 10, which is Ohio, completed all of its contacts the following week, all of them. Every veteran who was waiting, they called. Can we make it faster? Yes, but we had also identified $300 million in requirements in the immediate term.
Now, if you rely on a broken system, you're going to get broken results. So I encourage you to find a model, a benchmark, form a special operation unit that not only identifies physicians within the national VA system, but also within the private sector to rapidly deploy to the priority healthcare systems and create a form of healthcare event, a health fair, or triage, and get them seen sooner than relying on a broken system to fix itself.
Mr. Ruiz, may I respond to your desire for criminal investigation?
Yes, sir, please.
The 69 additional facilities that we have sent rapid response teams to are all criminal investigators. We coordinate with the FBI on all of our investigations. It's a requirement of the Attorney General guidelines. Whenever we open an investigation or the FBI opens an investigation, there's mutual notification so that we're not wasting resources, but also for safety and efficiency considerations so you don't find yourself going to arrest the same person at the same time and have someone get hurt. But trust me, we have an excellent criminal investigative staff, and they're pursuing all leads in this matter.
One additional item that I would make reference to in the case of Phoenix was the use of the disaster and emergency medical staffing team, which we call DEMPS. That is now being used in Phoenix. So we have a cell, which is a whole number of clinicians, physicians, nurses, and others who have identified and are willing to move across the country at a moment's notice. I think starting on Sunday, there were 21 such clinical staff on the ground in Phoenix providing care.
Well, I look forward to working with you to see if we can extrapolate that experience to other VA systems, including Los Angeles and other areas like Loma Linda, where they might have very long wait times that's causing harm to our patients.
Thank you, Doctor. Dr. Benishek, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Mikulski, I kind of feel sorry for you being here today because you're really representing a system that really has no defense, and I appreciate your apology at the beginning of your statement. And I'll just start today by looking at page 27 of the VA's internal audit, which was released today. The medical sister in the Oscar G. Johnson VA Hospital in Iron Mountain, Michigan, was listed as being in Wisconsin. Now, you can't place the facility in the right state, so I don't know how we can trust you with the big stuff. And like I said, I feel sorry for you standing there today. You know, the IG's interim report said that the VA told them the wait times in Phoenix averaged 24 days, with 43% waiting more than 14 days. But when they went there and took a similar sample, they found the average wait time of the sample was 115 days, with 85% being more than 14 days. How are we supposed to trust anything the VA says about this?
Dr. Benishek, thank you for your question. I would just tell you that we had a few slight version control issues towards the tail end of this, and we know where Iron Mountain is, and it didn't make it into the final draft. I would tell you...
how am I supposed to trust this data you did today, you submitted today, when you know, the last data you submitted was completely different than the IG reported shortly thereafter? You see the problem that we have here, Mr. Kowski. I feel sorry for you sitting there.
Every 2 weeks from here on out, bi-monthly, we will produce data. As our integrity and our reporting improves, we may likely see that our timeliness worsens.
All right. Well, frankly, I don't believe you, Mr. Mikulski. I tend to associate myself with the thought of Mrs. Kirkpatrick across the aisle there, who said that this system needs a complete revamp and restructuring because there's no accountability here. There's complacency. I like to associate myself with Mr. Ruiz, who strongly recommend prosecution, and with you, Mr. Griffin, for your comments about people aren't getting fired for not doing their job. And frankly, I think we need leadership at the VA, and hopefully we'll get that, where we have some leadership that will make people responsible and fire people that are not getting the job done, because this culture of not being able to get the job done and it doesn't matter is got to stop. And I appreciate your comments. We kind of slid them in there in your testimony that people need to get fired. And we need to make that happen despite whatever the work rules and all the criticism that we get. We need to have a system that the management at the top can fire the people that aren't doing the job and to listen to people at the ground who have the comments. Dr. Rowe talked about the simplest thing that every private practice in the world does is they call the patients a day or two before the appointment to confirm that they're coming to the appointment. And the VA hasn't figured that out. I mean, it's impossible to believe that that actually occurs. And that, you know, the appointment people are writing people letters telling them when their appointment is without talking to them. It's like, really? Nobody's getting fired over this kind of decision making? I mean, it's just unbelievable that this is occurring. And I appreciate you, Mr. Griffin, for your comments. And we need to have leadership within the VA and a system within the VA that holds people accountable and makes it known that if you don't do your job, you're going to be out of there or you're going to be prosecuted. Just simply that happening will change the entire culture there. Mr. Griffin, could you comment? I have a few more seconds left on where do you think this leadership should come from? Do you think it should come from the top, or do you think it should come from the bottom? Or give me some more comments on your thoughts about this.
I think you need leadership up and down the chain of command. What we have witnessed on some of our previous work was that VHA has sent out requirements, they sent out safety alerts, they directed the medical centers to address the issue and to certify that they had taken corrective action.
Does somebody sign these certifications, Mr. Griffin?
Just to finish the thought, we went out unannounced and determined that 42% had actually did what they said they did, and the other 50% did not, even though they certified that they had accomplished the directive.
Without any consequences to their career?
Not that I'm aware of. I would ask VHA to speak to that. I'm not aware of anyone being held accountable for that, but I don't know how you could not hold someone accountable for direct disobey of an order like that.
But it apparently occurs every day, Mr. Griffith. I'm out of time. Thank you.
Thank you, Dr. Binderscheck. Ms. Custer, you're recognized for 5 minutes.
Thank you, Mr. Chair. I want to thank you all for being here and for your candor under obviously challenging circumstances. But the comment I want to focus in on is restoring trust, because I think that's the challenge that we have, the integrity issue above all else. I'm interested in the notion about this decision to acquire a scheduling system that works in the private sector. Is that the intention, Mr. Matsufsky?
Yes, I'm not going to get into the arcana about our scheduling process versus the private sectors. I just want to address one comment. You know, this audit that we did was designed to be the start of our change. I just want to be very clear. If anybody thinks that I am not committed, if the team that did this is not committed, if we are not committed, please understand that we are committed to this change. This is the start. It's not the end. It's not the final report. In the private sector, we see resource-based scheduling, which is the resources of provider, their clinical resources, using telehealth or other mechanisms to deliver that care. In the VA, we have grown up around something we call sort of clinic-based scheduling. So we manage clinics as opposed to resources, and it makes it tough for us to be able to aggregate all of those views of one provider and know how many slots does Dr. Smith, how many slots does she have. It makes it tough for us to do that. That's not an excuse, but we do need to move to resource-based scheduling, which allows us to know how much capacity do we have in our system and how does that map to the providers we have.
So we've referenced what I think is causing the exponential effect of the loss of effective appointments with the no-shows and the canceled appointments. I won't dwell on that, but getting back to the resource-based, you mentioned that there's not an infinite supply of medical personnel, and that what we're talking about is a lack of slots. I wanted to focus in on the issue of graduate medical education, and one option that I've seen discussed is to relieve medical student debt, whether that's physicians, whether perhaps there could be greater use of nurse practitioners, ancillary personnel, and I'd like for you to address that in terms of the quality. In my district, our White River Junction Healthcare Center is very closely affiliated with Dartmouth Medical School, and it's a very positive arrangement, but I think we could replicate this around the country.
We can. I think we had discussed it a little bit earlier about the nature of our academic affiliations. It provides us a wonderful opportunity to recruit new young talent, have them exposed to the mission of our organization, which is a noble mission and a dedicated workforce, and the people we serve, veterans, to attract them to that mission is something we can do. We do have certain authorities to offer repayment and other programs as an incentive, and I think there has been some discussion. I would have to take it for the record to give you a precise answer on what the nature of those costs may be, but
I think it's something that we could look into as well on a congressional basis, is the idea that relieving medical student debt.
Absolutely.
In exchange for service within the Veterans Affairs. Could you address the issue of nurse practitioners and ancillary services in terms of providing greater access, more efficient access?
There I will get myself in trouble, Congresswoman, so I will take that one for the record. Okay. I know it's a discussion we are having.
I'd be very interested. I mean, certainly in the private sector, this is something that's happening across our healthcare delivery system, using more physician assistants, that type of
I do know that it is something we're looking at.
Okay, great. And then just in closing, back to the issue about restoring trust and integrity, I appreciate the comments here. Thank you, Mr. Griffin. I tend to agree with you. I think a few high-profile prosecutions would clean things up rather dramatically, but I think it's important and the time has come. So thank you very much. I yield back my 20 seconds.
Thank you, Ms. Custer. Mr. Huelskamp, you're recognized for 5 minutes.
Thank you, Mr. Chairman. A couple questions following up on the issue of restoring trust. Ms. Moody from the VA was before our committee, I guess 2 weeks ago, and her stated goal was to be open and transparent in working with this committee, members of Congress, and hopefully with the public. Are you aware of any gag orders or orders, instructions from Washington that were forbid employees from visiting with the media and or members of Congress about these issues?
I personally am not, Congressman.
In Wichita, at the Dole VA Center, let me give you a little background on that. As of Friday, May 30th, U.S. Senator was told that there was no one on a secret waiting list. 3 hours later, a letter was released from the center that said there were actually 9 individuals on the waiting list. And at that time, on a Friday afternoon, evening, I began calling the leadership at that center and received no response until following Wednesday, when I began hearing rumors of 385 on a secret waiting list. I jumped in a vehicle, drove the 1 hour. It happened to be fairly close to me for my district, and there was met with an email from the VA that forbade employees from visiting with members of Congress about these issues. Now, if that indeed was an accurate email, do you think that helps build trust?
It does not, sir. But
You're certainly not aware at all that those type of emails were sent out through the VA system, or at least there were actually, and they wouldn't provide me a copy of the email, I think there were probably 100 different names it was going to. I didn't know them. I knew the one sentence at the end, which said, don't talk to anybody. So you're absolutely not aware of any such email?
I don't know, Congressman. I've been sort of working on the audit and some preparations. It is possible that
well, why would an email like that ever be sent out?
I think the one reason, Congressman Huelskamp, would be the following reason. We were going to release an audit that would contradict a statement that someone locally might make to say everything's fine, we have no issues here, and we're about to release an audit that might contradict that. So that would be the concern that I would have. I would hate for somebody to tell you everything is fine, and along comes an audit that says not everything is fine, and oh, by the way, here's the official data.
And your audit that you've released today identifies 104 veterans waiting in Wichita
Correct.
For care. The facility says 385. How are those two numbers different?
I will need to compare the numbers.
Well, 104 to 385. There is a difference.
Well, here's how. And I'm not certain that this is the cause. But the data that we published today was current as of May 15th. If you went to the facility on May 30th, you would pull a local number that might be bigger. One of the things that we identified with the audit as we went to sites was that prior to coming to the sites, there started being a change in some of the schedules.
Let me interrupt you in this specific circumstance. The facility said they knew of 385 on May 21st. Then they told the public and Senator Roberts 0. And then they told us 9. Then they said maybe 385. And until I knocked on the door, they wouldn't confirm the 385.
Okay.
And so the numbers have changed. And then in the middle of this, you have a gag order. One other issue I would like a quick response on that, certainly much quicker than the March 2013 request I gave to the committee that's not, to the VA that's not been fulfilled yet, is how do you handle folks who game the system illegally in clear violation of the policy? And I asked you at that time, has anybody been fired or punished or otherwise for violating those rules?
We have begun the removal process for a leadership team in one of our medicals.
You have not yet responded to that question. I have not seen those policies.
I'm sorry.
Is there a reason you didn't respond to that question in committee?
I'm not sure what the question was, sir.
Well, you can go back to the testimony. I'll be happy to provide that to you again. But that question matches up with a April 26, 2010 memo. And I know my colleague kind of felt sorry for you, but this is not new stuff.
It is not.
It is not new stuff. And you came before this committee, I wasn't here yet, and said you had 26 different schemes for gaming the system. And have you changed any of those? Has anybody lost their job for doing this? We know veterans have lost their lives. And I don't have any clue or any information anybody's been punished, that anybody's lost their bonus, or otherwise because of something you've known for years. 36 different reports from the GAO and the OIG about this, and you come here and say, we're going to do better next year. Yield back, Mr. Chairman.
Thank you, sir. Mr. O'Rourke, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Draper, you, first of all, I appreciate your work, and I'm learning a lot listening to you this evening. And one of the things you talked about was the cancellations and the no-shows. And in El Paso, we've heard anecdotally of cancellations that are recorded as no-shows. A veteran last week, for example, told me that she had gone to the VA in El Paso for a mental health care appointment. A second appointment was made by that psychiatrist. The VA called her to cancel that appointment. She thereafter requested a copy of her medical record and found that that cancellation was recorded as a no-show. So it hits against her record, doesn't hurt the VA's wait times reporting. Have you found evidence of those kinds of practices in your investigations thus far?
Not specifically that, but we did find, as I mentioned, more than 50% of the 150 cases that we looked at had at least one no-show or canceled appointment. And, you know, we found clinics, we found in 10 of the, we looked at, for each facility, we looked at 30 consults and 10 consults per the 3 specialty areas we looked at. And so we did look at one of the, it was interesting because one of the specialty areas, they canceled all 10 appointments. All 10 of the appointments that were in our random sample were canceled. So it raises questions about whether they were really canceled or there were other things going on. So
we, in El Paso, had long heard from veterans who said that they couldn't get a mental health care appointment and certainly couldn't get it within 14 days. The discrepancy between what the VA was saying, which is that they were seeing everyone within 14 days, and what we're hearing from veterans was so great that we commissioned a survey. We released a report last week. We found that 36% of the veterans in El Paso requesting mental health care were unable to get an appointment at all. And I want to thank you and the VA for not challenging the facts. It was a well-designed, well-implemented survey, large sample size, and instead the VHA is now working with us to identify those 1/3 of the veterans, hundreds or thousands of veterans in El Paso who could not get a mental health care appointment. And so I appreciate that. And I also appreciate the audit that you released today that shows that new patient mental health care average wait times in El Paso are 60 days. That's the 4th worst in the nation. But I'll tell you that May 9th, I received this report from Dr. Petzel and Mr. John Mendoza, the VHA administrator in El Paso, that showed that 0 veterans waited more than 14 days, not just the previous month, but the month before that, and at worst, 15% of veterans waited more. So, you know, a simple question following your audit, which should I believe, the information that Dr. Petzel gave me that showed no wait times over 14 days, or your information today that shows that it's 60 days?
The information today. And I would tell you that as we improve the integrity of our reporting and our wait times, the established patient data may also get worse as it becomes a more valid reflection of reality, and that is important to have.
That bad news would be welcomed because, as you said, it would be rooted in reality and the facts and in what we're hearing from our constituents and the people we serve. And we will not be able to correct this problem until we know how extensive it is. And so I appreciate your commitment to that as well. And on a related note, I will be introducing a bill this week to essentially replicate what we did in El Paso throughout the VA system. We cannot right now trust the VA to tell us how the VA is doing, but we can trust veterans to tell us how the VA is doing, and we should ask them directly what their wait times have been. I really like your commitment that you made earlier, that when you have a no-show, that veteran who's been recorded as a no-show will have a phone call from the VA to confirm that that is what has happened. Was that essentially what you committed to earlier?
I have. We do patient satisfaction data today, and veteran patients, by and large, rate the quality of their healthcare experience overall as very high. But they also tell us in our satisfaction surveys that they rate their access as pretty low.
So I would just ask for your continued cooperation. We're going to introduce this bill this week, the Ask Veterans Act. I think having an independent third party, the OIG, the GAO, someone apart from government altogether asking veterans what their wait times are is part of the solution, in that we will get real information that we can then make better decisions from. So appreciate your help and appreciate the testimony and the expertise from everyone on the panel. And with that, Mr. Chair, I will yield back.
Thank you, Mr. O'Rourke. Mr. Kaufman, you're recognized for 5 minutes.
Thank you, Mr. Chairman. First, I want to thank the Veterans Administration here today. This is the first, this is my second year on this committee. And I'm proud as an Army Marine Corps veteran. I'm proud to be on this committee. I'm proud of the members of this committee. It's the most bipartisan committee in the Congress. Republicans and Democrats standing shoulder to shoulder to make sure that our nation meets its obligations to those who serve this country in the military. And I feel that every hearing I've had prior to this, it's deny, cover up, and then delay giving any information to us. no accountability, no transparency on behalf of the Veterans Administration. And I got to tell you, I think there are a lot of great men and women who work for the Veterans Administration, and a lot of them are the whistleblowers who have put themselves at risk. That if not for them, we wouldn't be here today, cleaning up this problem. And so, I just want to say that I think a third, if I understand it right, of the men and women that work in the Veterans Administration are in fact veterans themselves. And I would love if you would look at increasing that, whatever you can do to increase that number. I think that there's nobody that understands the needs of veterans more than those who've worn the uniform. And so whatever you can do to get that third up, I'd really appreciate it. So when we get to this 14-day wait period, and then I heard that its quote was simply not attainable, unquote. What is realistic?
I honestly don't know tonight. I do know what is unreasonable. I think 90 days is unreasonable. I think 60 days is unreasonable. I don't know what the right measure is. We have to study it. We have to look at what is right for an individual veteran is based on his or her own preferences. Acuity also needs to come into the mix. For cardiology, 14 days is not soon enough, right? It has to be based on an individual veteran's requirement. I think setting an across-the-board standard encourages an attempt to meet that standard. We'll still measure timeliness. We'll still aspire to be faster, but we won't tie rewards or incentives to that activity.
Didn't that benchmark, when you interjected financial rewards into that, fuel the incentive to manipulate these wait times?
I didn't ask, I mean, in our surveys, we didn't ask people. I mean,
in your opinion, don't you think that it was a financial reward that incentivized this behavior, that the secret waiting list where veterans were ultimately denied care as a result of this manipulation?
Simple act of stating this is our goal, you shouldn't do anything other than this goal, even without a financial incentive, might drive that behavior.
Wouldn't they have spoken out, though? Wouldn't they be more inclined to speak out without the financial incentive that what's going on is wrong here?
We have to look at that second question. I think they're two separate questions, sir.
Okay. What is the, I just think it's going to be so hard. I think that this culture of bureaucratic incompetence and corruption is so deep, and I appreciate that the forthright, I think, nature of your testimony today, but I think it is so deep and so ingrained in this organization that it's going to be very hard to turn around. And what I hope occurs from this is that veterans have a choice, that veterans have an option, that if you're not able to meet their health care needs, that they can go outside the system. And I hope that then incentivizes the Veterans Administration to see them as customers, to see them as their patients. And right now, I don't think that's, I think there's great variances between facilities, as you mentioned, I think across this country. But I think that there has to be an incentive for them to see them as their patients, for it to drive some quality standards, for them to care.
If our veterans are happy and more of them choose to come to us, we're having a good year. If we can deliver safe, quality health care that is timely, we'll get there.
And if you're not, they ought to be allowed to go outside the system, reimbursed by the VA. And I think, as you mentioned, Dr. Draper, the management structure really isn't there to support that, and I think it needs to be developed to support that. With that, Mr. Chairman, I yield back.
Thank you, Mr. Kaufman. Mr. Walsh, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you all for being here. I think all of you here, when our system of government works right, we're to be a reflection on our constituents, and I think you hear it. You hear it, I would hope, loud and clear, the frustration, the lack of trust. It's universal. Many decades of good work can be erased very quickly by bad actors. And the question is where do we go from there? I want to thank you all for the work you did on the IG and the GAO working together on that. Ms. Holliday, we go way back on some of these things. And when the system works right, you were here with Dr. Rowe as a ranking member, with Murfreesboro and Miami with the contaminated equipment, we brought in best practices, we fixed that, we implemented it across the system, and by all accounts, we made a correction based on that. So there is a model there to try and do this. With that being said, if you look around, there are many in this room that a long institutional knowledge of both the military, the VA working on this together. Many of them are sitting behind you, and many of them have been coming and talking to us and telling us there were issues. So the idea that this is anything new is incredibly frustrating to many of us. The breakdown comes when I have to be very honest with you. I think I've proven myself of trying to get this right when I am seen as more of an obstruction and a nuisance to answer questions when we call over to try and get them, instead of being a partner to fix this. And that in itself is systemic cultural issues. For example, I have an institution in my district that has offered to help and I've gotten no response. When the Mayo Clinic wants to help you with this, perhaps I can get a call. Perhaps someone will call back, but this has gone on and on and on. I am at a loss to understand why that is, because the people here are committed. They're speaking with the voices of their veterans. They stand. There's people sitting back behind you that sat in my office and asked us to do this, and we send a letter in and get nothing back from it. So, Mr. Makowski, you've heard it, and I think your sincerity and the work you've done, certainly I'm not going to question it. But the issue we have here, and I'm reading today, this was from Dr. Haney and Armstrong. They were up at Syracuse, and this is how they started out. They quoted Peter Drucker and said, "The greatest danger in times of turbulence is not the turbulence, it's to act with yesterday's logic." And their question was, where's the big idea? My question to you is, where's the big idea for reform? Because if you're going to come here and ask for technology money, that was a cursory thing they found. When they pulled the testimony of the people who sat there and the questions that I sat here and asked about technology, you are going to be embarrassed, and my guess is you will not want to come and ask for that money. That is what I would anticipate right now. So my question to you is, where's the big idea? Where's the vision?
I think the big idea, it may not sound like a big idea, but it is back to basics. Back to delivering safe, quality health care in a timely manner, knowing where we can achieve that, where we cannot. I think it's an open engagement with our partners. Veteran service organizations weren't mentioned enough today, but they are our partners. When we actually talk and listen with them, they have good ideas for us about how to get back to basics, how to listen to veterans, what they want, what they're telling us. I've worked with members of this committee staff in the past. Some of those things actually, when we listened and worked, were when we started measuring wait times that were too long and directing care to veterans who we thought were waiting too long. I don't have a big idea, sir. I think our idea is back to basics. It is a good system. It can be a great system. It has phenomenal employees who are mission-driven. Our big idea is to get back to basics to deliver veterans care in their system.
Mr. Griffin, is that possible as it currently stands with the leadership and the structure that's there, in your opinion?
In my opinion, it's going to take a fair amount of time. It won't happen overnight, that's for sure. There are a number of different areas that need to be addressed. And when you're talking about timely quality care, one of those is performance standards. I've heard Dr. Rowe talk previously about people who do GI work in the private sector, and maybe they're at an HMO or somewhere else, and they know every day I have to do X number of colonoscopies every day. And when we did our review in December of 12 of specialty care, we looked at 33 specialty areas, and only 2 of them had performance standards. The other 31 did not. So if you don't know how many colonoscopies you're going to do in a day or how many other procedures, you need that basic information in order to be able to then generate the number of doctors you need.
And I, like my colleagues, have been questioning all the data. I'm questioning the satisfaction surveys. I'm questioning everything that's coming out now, and it's very frustrating. I would leave it with this before my time runs out, too, is today in this report that comes out, and you heard Mr. Denham and you heard others say this, when you flagged those entities that are out there, those locations, you do realize every single veteran that attends those is tonight calling, wondering, asking, what happened, what's there, what's going on, and we don't have a hard timeline when you're going to come back. We don't have an idea where it goes. So now, instead of creating a transparency and an honesty and a reconciliation on this, we've created another layer there that is causing angst amongst veterans. So I would just encourage you, we got to look at this a different way. I yield back.
Thank you, Mr. Waltz. Dr. Winstrup, you're recognized for 5 minutes.
Thank you, Mr. Chairman. And following up with what Mr. Walls was just referring to, last week, the White House Deputy Chief of Staff, Rob Neighbors, visited the Cincinnati VA Medical Center, and that's an area where many of my constituents are veterans that go there. And I learned that as a result of the internal audit that they were flagged as requiring further investigation. So at this time, can you tell me what's happening at the Cincinnati VA Medical Center that got them flagged? And should veterans in my district be apprehensive about the care that they're receiving or the timely fashion in which they receive it?
They should not be concerned about the quality of the care they are receiving. I think, there are specifics behind each one that got listed. In some cases, I'm not saying this is Cincinnati, but in some cases, it could be just a single concern that came in as an anonymous whistleblower concern at the time that we were there. And we felt in those cases that we needed to make sure that we listed that.
Well, do you know when we'll get the details of why that was flagged and what we should be?
I do not know yet, but I will accelerate that. We have to move that quicker so that we reduce the level of angst, as Congressman Walls alludes. We have to do that. So I will double down and make sure we get that done quickly.
I would appreciate that. You know, the problems that we have within the system, in my opinion, I come from private practice as well, that, a veteran seeking care is in some ways a liability to the VA system or to those that administer, and that's a problem. They're not a desired customer, and then we've talked about that. Dr. Rowe talked about it, Dr. Benishek did. And, we really need to have incentives for quality and incentives for proficiency. And, we need to see, in private practice, a no-show is a liability, a huge liability. You can't keep your doors open if you have no-shows. And there needs to be not a reward for this. There needs to be a reward for coming up with ideas of increasing access, which a private practice will do. How can I see more patients, get the patient in with the doctor in a more timely fashion? The other thing I'm concerned about is with the consults. There's obviously sometimes with consults a level of urgency, depending upon, as you mentioned before, the acuity of the problem. And, if I'm referring a patient for an acute problem that needs to be addressed right away, I will get on the phone and talk to that person I'm referring to say, can you get them in? Will you get them in? This is something that we do in private practice. You want to make sure that your patient is taken care of. Also, when we have a no-show, if it's somebody that you've been treating and they don't show up, as a practitioner, you have a personal responsibility to that patient. You're finding out why they missed. And if they need to be in there, you get them in that evening, the next day, whatever the case may be. My feeling as you move forward, and you talk about a big idea, is at the administrative level, we got to look for someone outside the VA. Because if you've spent your whole career in the VA system, you don't know what you don't know. You don't know these things that make an efficient system. It's not on your radar because you haven't had to do it. And it is changing an entire culture. And if you're going to get somebody from within the same culture, we're probably going to have a problem. We've got to have people that understand what competition is about. And as you said, if somebody desires to be at that VA, that's a good day. And that's what the VA should be seeking. But the only way you're going to get that and deal with human nature is to have competition. Would you agree with that concept of maybe coming from outside the VA?
I'm an old consultant by training, so for me, time was money, and the availability of your time was billable. Now, I think there's a balance. We don't want to turn into, 15-minute appointments or 10-minute appointments where nobody looks at you. There has to be a balance, but there has to be accountability for time. We talk about resources and the management of resources. Time is the most valuable asset in our system. We have to manage that time. We have to extract value from it. We have to be respectful in the way we do it. But I would agree, competition, to know that we can get more clients, more veterans who want to come in our system, who are happy with our system. We need to introduce some of those concepts into our thinking.
It isn't just the time. I mean, it is the quality of care and the patient's perception of are they being cared for. That's always a challenge in private practice. Somebody needs more time than someone else, or someone needs more time than you maybe planned on that day, but you give it and you find a way to work within that system to make sure that when they leave there, they feel satisfied. So my advice at this time, one, I want to hear what's going on in Cincinnati, obviously, but I also would really suggest that we take a look outside of the VA system, because if that's been your whole life, you don't really understand how it could be, and I think competition is the key, and I yield back.
Thank you, Doctor. Ms. Walorski, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Makovsky, I find myself, again tonight, I associate myself with the comments of everybody on this committee, and the more I learn sitting here by the questions they're asking, the more baffled I am on the things that we heard 2 weeks ago and the things that we're hearing tonight. But primarily, I guess on behalf of every American taxpayer, where the heck is the money, the billions with a B dollars that this Congress and previous Congresses have allocated to IT upgrades? What do you tangibly have? We funded all kinds of things the chairman just read. What did the VA tangibly spend money on that is working right now?
I would have to take that one for the record. I mean, there are a number of things that we have developed and delivered in the IT domain. You know, we have a Veterans Benefits Management System, which is a paperless claims development system for VA.
Sir, and I apologize for interrupting, but Ms. Kirkpatrick asked the question and you gave the answer. We're using 1985 programs. 1985. I've only been here 18 months and we've allocated millions of dollars, and the IT people sat right here that I think somebody else referred to, and we asked and asked and asked all kinds of questions. In fact, I specifically asked them, sir, who's in charge of the IT department, do you have enough money to purchase what you need to get this VA system moving? And the answer was, yes, ma'am. We've seen all these budgets. We've funded everything under the sun, and it is baffling to me. It has to be baffling to the American taxpayers watching tonight that we're using 1985 antiquated system. But here's my other question. I guess the thing that I think is very, very interesting is, did you not have any idea, based on Mr. Griffin's comments from 2005? I've only been here 18 months. I've heard IG report after GAO report after IG report, and I know there's a problem. But in the system, and you said you're the business side, you're the engineering side, did those IG reports never make it to you?
I reviewed the GAO report, and I believe we had testimony here in, I think it was April of 2013. In response to that GAO report, we went back and looked at how we computed the wait times for veterans who are new to a clinic. Maybe not new to our system, but it was the first time they were going to podiatry or... And
were you satisfied with the results that you came up with and thought that you fixed them?
No, we changed the performance measure from using the desired date to measure new appointment wait times, and we switched to the create date. It gave us a much more valid measure. We started measuring veterans who are waiting longer periods of time, and we started trying to change that.
And obviously, but can you say that today that's a failure? What you guys did at an intermediary level was a failure?
I would say that we did not know at that point in time, Congresswoman, the nature and the scope of the problem.
Well, I guess the two things that, I came away with 2 weeks ago was this. There has to be a criminal investigation, and to know that there are 69 criminal investigations going on tonight, I think is breaking news to the American public. And I agree. Indianapolis and Danville, Indiana are on your list for further investigations. My Hoosiers in state of Indiana are going to ask the same questions. Well, what do I do? Well, when are we going to get the information? And I guess I'll take it on the record that we're going to get information when you get it. But I have a question for Dr. Draper, because it goes to this issue of IT, because I'm sensing that where we're going to end up in one of these grand revelations is that this IT department, this IT system is unbelievably messed up. And we've asked the questions, but have not been provided truth when it's come to those kinds of things. But Dr. Draper, as you know, the VHA is only permitted to use one authorized electronic list, the EWL. According to your written testimony, ma'am, officials from a VA medical center that was piloting another electronic system stated that after evaluating the pilot, they decided not to use this approach. Do you know if that pilot program was vetted by the VA's OIT office?
Well, we found that when we spoke with VA that they have not done a system-wide check to see what people are doing. This is related to the future care consults that are
correct. But would you identify that problem as being? Would that program be legitimate through the eyes of the VA?
It may not be legitimate. I mean, one of the problems is some of those programs, the data doesn't end up in the consult's data that is going to be used as a monitoring tool system-wide. So it can be problematic.
And could that not be also considered a separate electronic system, a separate electronic list? If nobody has vetted it, if nobody's in charge of it, but there's a system that is out there?
Well, we've seen in the last few months as the business rules for the consults, the new business rules, that also the medical centers that we've been speaking with, the 5 included in our review, they're changing their processes. So they started out with something and they've changed their processes. So it's really very confusing, and I think that you know, all the different ways that the medical centers are using, you know, tracking those future care consults has not really been vetted always with VA.
Thank you, Mr. Chairman. I yield back my time.
Thank you. Colonel Cook, you're recognized for 5 minutes.
Thank you, Mr. Chair. I guess everything in Washington comes full circle. And the old term, waste, fraud, and abuse is going back through my brain housing group tonight. But a couple of questions. By the way, Mr. Griffin, unannounced inspections. I am delighted that you went in there. Ms. Titus, the last time we had a hearing here, she asked a question about one of the individuals on the panel that came down to Phoenix. I believe it was on a Friday, didn't work on the weekend, and left the beginning of the next week. Has anyone declared a state of emergency, decided to say, hey, let's work weekends, let's work maybe 6 to 6, if we're going to send striker teams, or if people are dying on our watch? Has this ever occurred to people to, hey, we got to do something about this? Mr. Makowski?
Absolutely. We are encouraging and requiring our staff to work longer clinic hours, nights, weekends. We're all working.
But maybe I'm missing some encouraging. I'm looking for a better action verb, like, can they go down there?
Yes, we have put folks on the ground in Phoenix. They have been on the ground working, fixing the problems on the ground at my direction. They are working hard. They are finding ways to improve the practice. We are bringing folks in from our disaster and emergency medical provider system. They are personnel system. They are on the ground as of Sunday to work Monday morning on the ground. Okay,
then let's go back the subject of mission performance standards, public administration 101, if you will. In the military, there's a number of us that were there. We evaluated combat units, whether they're C1 or C4, fully combat ready or not combat ready. And I have to ask myself, are some of the hospitals fully mission capable and some not mission capable, or others partially? Do we ever evaluate that in accordance with the mission that we have to take care of our veterans? Because I'm getting the feeling, and I'm not trying to lead you, but I'm getting the feeling that each hospital does their own thing because the policies are different and open, ambiguous, if that was the word that I heard correctly, and open to interpretation. Anyone?
We have some great facilities. I think we also released today data that shows quality, efficiency, and others, and provides quantitative comparisons of our hospitals. And there are some that are lower, and we work with those to try to improve their performance directly.
Yeah, Mr. Griffin, you kind of hinted on this, and you know what you're talking about, trust and all those things, which I think some of us all believe in. But unless you have standardization coming from Washington and verification of the outcomes, are we working at cross purposes if it's open to interpretation?
I think the expression trust but verify.
Absolutely, and that's where I was. You're stealing my stuff.
In our organization, we go to 50 medical centers a year for a one-week review on specific areas of interest. We go to about 100 outpatient clinics a year. And then we roll up the results, and we can tell the Undersecretary at Veterans Health Administration that X% of your facilities aren't measuring up in these two categories. And then we would expect there to be corrective action on those.
You know, I haven't followed this, and I'm sure you got whistleblowers and everything else, but after I got out of the Marine Corps, I became a college professor. Dangerous place for me to be. But every student nowadays, they have a thing called rateyourprofessor.com. And I tell you, you want to find out how good, bad, indifferent you are, or whether the student is just, read that. And I'm just wondering, because I was trying to go through about and look at different hospitals. RateYourVAHospital.com. Sometimes it's eye-opening, and sometimes you need that self-evaluation. I obviously am looking for a more standardized evaluation method on whether they are completing the mission. I would hope we could do that, or we're just going to have, I think, bad results in the future.
If I could respond.
Yes, sir.
In our combined assessment program, where we go to those 50 facilities, one of the last documents in the back of those reports is a VHA document called the SAIL report, and it ranks every hospital on about 100 different performance metrics, and it's published in those reports. So the data is collected and it is available. Now someone needs to act upon the ones that aren't measuring up.
Can I also respond to your?
Yes. Please.
Yes, just what we found, there's a great reluctance on the part of VA to standardize policies and procedures, and that leads to also complications when you're trying to do oversight. So I think there are issues there.
No, the only thing I wanted to say, this came up this year with the cuts to all the military units. If there's a deficiency of training, equipment, and everything else, this report, what have you, would have those deficiencies that could be corrected. And all I'm saying is I would hope that the VA would look at more standardization from my standpoint.
Thank you, Colonel. Mr. Jolly, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Just to confirm, Mr. Griffin, you said there were 69 cases where you are now following up to review possible criminal implications.
There are 69 separate facilities beyond Phoenix that we have sent rapid response teams to as allegations have come into us.
Specifically criminal allegations?
No, they're first of all, they're just allegations.
Sure, no,
we send criminal investigators there to take sworn testimony and try and get to the ground truth. But in some instances, sure, you're only as good as your source, right?
Sure, no, I understand, and,
right,
and allegations have to be vetted out.
Right.
But
yes, sir.
You use the term criminal, and I wanted to confirm.
That's right.
Okay. This is different, though, Mr. Makovsky, though, from the follow-up visits that are required of some of the institutions based on your audit, correct?
That is correct.
Totally separate, okay. The timing, and I know it's come up for additional information on those follow-up visits, is it weeks or months? I realize
weeks, sir.
Weeks.
Weeks. We'll be working with the Office of the Inspector General this week, putting together a plan, which we've already started, and then it'll just be a matter of weeks. I agree that we need to make sure that veterans understand that their care is still quality care, and that what we've identified here is questions of practice integrity.
Great. Mr. Makovsky, I want to thank you for your candor this evening. Congress often gets frustrated with trying to get information from this administration. You are demonstrating an exception to that tonight, and I want to compliment you for your honesty and your references to some of the frank problems within the VA. You spoke about non-VA care in your terms being now the veteran's choice. And this is one of the issues that I've raised repeatedly now. I think within the current system, the ability to get to non-VA care sometimes is obstructed by a process where a patient has to go to the very same medical staff that said they didn't need it. Has that changed? Your term now, patient's choice, has that changed?
It is changing, sir. It's going to take time. In conjunction with accelerating care, we provided training to roughly 1,900 of our facility and regional staff. That was over a period of about 6 days. In addition to that, we've since offered and delivered training to about 2,700 staff for appropriate use of the scheduling package and how to manage no-shows, how to schedule appointments, et cetera. It's going to take a lot of that. It's going to take a lot of communication, constant communication, and then frankly monitoring. If we see delays and we don't see use of non-VA medical care, it's incumbent on us in Washington and at the network and at the facility to ask the question, why?
Right. But has there been a change in the same medical staff that initially said no having to sign off on now saying yes?
The change is the degree of vigilance that we have in the communication of our objective that the veteran must be offered a choice.
Okay. Along those lines of analogous to non-VA care, I think each of you would agree tonight you've referred to it as a problem within management, at least places of management throughout the system, as opposed to the staff and some of the doctors that the veterans say provide great care. Currently in some VA facilities, private sector healthcare systems provide management, different than just seeing a non-VA physician. Is there value in expanding the use of regional healthcare system providers to provide the management? So I understand from a number of the veterans I speak to, they want to stay within the VA system. They like their VA hospital. So the idea that some have suggested of just feeing everybody out or using a voucher program is not something that I believe the veterans community would really embrace. But can we expand the use of private sector healthcare systems to provide management for facilities? What would your thoughts be on that?
In some cases, we do use that. As you know, with contract community-based outpatient clinics, we do have some partners in the private sector that help us manage some of our outpatient clinics.
But those are really smaller facilities, right? What about the very large hospitals where peer-to-peer, I mean, and let's be honest, it's not a criticism, there simply cannot be the private sector efficiencies in a large VA hospital currently. Is there value in looking at larger facilities and saying, can we provide private sector management?
Sure. I mean, I think we can look at it. The one thing that I would tell you, if this crisis has taught me anything, it's to question everything and the intent behind everything.
Has there ever been a comparative study of performance based on management from private sector?
Periodically, we do. The one thing that I would just one moment of concern. A lot of our measure of the private sector efficiency is a revenue-based metric, which is to generate revenue. So I would say that, you know, other agencies, Medicare and others, have had some issues with that. So our version of productivity, I would just ask us to have some measure of skepticism in the interpretation of that productivity data. It is tied to revenue.
I want to thank you again. I really do appreciate your candor, and I will tell you 2 weeks ago many of us were asking for urgency. I think we've heard that from you tonight. I know the acting secretary has demonstrated his approach as one of urgency as well, so thank you very much. Mr. Chairman, I yield back.
Thank you, Mr. Jolly. I do ask unanimous consent that the former chairman of the Subcommittee of Oversight and Investigation, Mr. Johnson, be allowed to ask questions. Without objection, Mr. Johnson, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to my colleagues for allowing me to participate. Mr. Matkowski, I too commend you for your candor. I want to focus a little bit more on the IT issue. As subcommittee chair of O&I, one of my very first requests of the VA was to show me the IT architecture for the VA. Now, I don't know what your IT background is, so I don't mean to be insulting. Do you know what an IT architecture is?
I do. I was in the systems industry.
Okay. Well, do you realize that it's now going on 4 years and we still do not have the IT architecture? You know, I sat with the secretary in his office and I gave him an analogy that he is very familiar with. As a battlefield commander, you would not go into a conflict. I mean, our young people that we are now trying to take care of in their veteran years, when they were serving, they depended upon leaders to make good strategic decisions and know what the enemy had out in front of us, know what our capabilities were to offset those risks and those threats. They have the same expectation now of the VA to understand what their needs are and what the capabilities are that are required to meet them. The VA has got hundreds and hundreds of IT systems. You made a statement a little earlier ago. You said, I think to my colleague, Ms. Walorski, one of the systems, you said you would not approve it until it was proven to integrate with our current system. How, in God's name, can you expect new IT integration to be complete and accurate if the VA still has no idea what the architecture of its VA IT environment is? You're spending hundreds of millions of dollars a year on IT-related things. And Dr. Draper, Mr. Griffin, Ms. Halliday, I hope that that's one thing that you'll take away from here as you're looking and investigating into what the problem is. part of the reforms that the VA needs to get to is coming into the 21st century with IT, not only in terms of systems, but in systematic processes and current state-of-the-art methodologies for managing those systems. Mr. Matkowski, when are we going to see what the VA plans to do with its information architecture?
Sorry, I'll have to take that one back.
I heard that 3 years ago, and I'm not trying to be disrespectful, but that's the same old question. It's like a dog race. You know, we come out every 2 years, and we chase that rabbit around the circle, and then we put the dogs up until we ask it again.
I think we have to ask, what do we want? You know, in this case, for scheduling, we want to be able to provide timely, accurate information about when veterans want to be seen and what capacity we have in our system to see them, whether we build that or acquire it. I would rather buy what the industry has and knows can work. The healthcare industry has something called HL7, which is the interface language. Most modern systems speak that language. So does, frankly, our old legacy VISTA system. I would not look to have really complicated interfaces, but rather to leverage what the industry can show us.
Well, I would agree with you, because I suggested to the Secretary in 2012 that, you know, he said his 3 priorities were eliminating the homeless problem, reducing the backlog, and getting an electronic health record. And I would not approve a single new dollar of new IT spending until someone in that IT department could show me the current architecture and how all of these systems fit together and how any new IT spending is going to affect that. And let me make one more point, because I'm running out of time. You talked about the electronic health record, and you made some very positive comments. Now, I confess that I don't know where the status is as of today, but I can tell you that at the end of 2012, we had a joint hearing with Secretary Shinseki and Secretary Panetta, and they were proudly saying that we were going to have a single transparent electronic health record for our military from start to finish within the next 5 years. You've been working on it for 10 years. This is not a matter of can do, it's a matter of want to. And the department does not want that electronic health record because the IT technology to get it is there today if they really wanted to do it. Mr. Chairman, I yield back. Thanks for giving me the opportunity.
Thank you very much, Mr. Johnson. Members, the clock says 10:10. We will stand in recess for 5 minutes. Hearing will return to order. We will start a second round of questions for those who would choose to ask. Mr. Griffin, if I might, in your testimony and in the interim report, you stated that the OIG is, quote, not providing VA medical facilities advance notice of our visits to reduce the risk of destruction of evidence, manipulation of data, and coaching staff on how to respond, unquote. However, in documents received from VA pursuant to the May 8th committee subpoena, it shows that OIG notification was provided to facility directors prior to criminal investigative visits at some facilities. Could you help us reconcile your testimony and the information that we have?
The original testimony that you read from us is as stated and accurate. There's been confusion created by some people at medical facilities who thought that the VA audit personnel were my personnel. We saw that on a number of occasions, alleging that we let directors sit in on the interviews. There was too small of a population of schedulers interviewed. That was not the IG interviews. That was the VA audit teams.
Okay, thank you very much for clearing that up. Mr. Matkowski, why haven't you already determined which non-VA providers are in communities? Isn't this the PC3 program that has been so highly touted? designed to identify qualified providers who can provide care when VA doesn't have the capacity to do so. You testified that you're going to go out and figure out who you can use. Haven't you? Shouldn't you have already done that?
Mr. Chairman, to some extent we have already through PC3. I want to set some realistic expectations. PC3 received its first authorization or referral for care in January, the contractors. So it's going to take some time to fully flesh out those networks and run at a rate that we want them to be. In some networks, in some regions, they may have difficulty finding providers, so we will continue to use non-VA care, previously known as fee basis, to find care. What we did, we provided the list of veterans who are waiting in our facilities for the particular types of care. We also shared that with our PC3 contractors to see if they had that capability and to understand our demand.
Okay, thank you. Also, we talked about Dr. Davies and the electronic wait list issue and the fact that it has grown since he first testified, but he also said that the wait list would be eliminated by April 1st of 2009, and it would remain at 0 by the 1st of July of 2009. So my question is, don't you think that would be the impetus for the problem and the fraud that's been perpetrated in regards to the secret waiting lists?
I think we need to be, Mr. Chairman, careful what we say. We should not be telling facilities that they should not have an electronic wait list. If our policy says that they cannot schedule a veteran within 90 days, they should go on the electronic wait list. If those clinic slots are not available, we're to record those delays for care where we can find them. So we should not be telling people to have no electronic wait list.
I guess that's an answer.
Sorry, sir. Let me be more direct. We should not state that.
I've got another question that my time is running out. I apologize, but you talked about credentialing and the time that it takes to credential physicians. Are you aware the Chief of Staff of the Miami VA Healthcare System Medical Center signed a consent agreement in 2009 with the state of New York never to practice in that state due to his failure to meet the standard of care for abdominal surgeries while practicing medicine in Florida? And in this regard, the Florida Board of Medicine has already fined this doctor $5,000 and ordered him to complete community service attending remedial training. So the question is, why is this doctor, twofold, why is this doctor still at the Miami VA Medical Center, and how is it he remains the chief of staff of a major regional healthcare facility?
So I found out about that last night and this morning and collected some data. I don't know the specifics of the case. I have to research it, and I will get back with this committee.
Would it be proper for that person to still be in his position if, in fact, that information is true, or would it be more accountability on your behalf if that person were to be suspended?
I cannot conjecture, as I don't know the specifics of the case, but if it turns out to be valid and these are valid concerns, then some appropriate action is comparable to suspension. I believe that there was a Merit Systems Protection Board and MSPB review. I don't know that for certain, sir, but I just have to go back and research
So the Merit System Protection Board is the same thing that Senator Sanders wants to interject into the bill that we passed out of this committee, correct?
I don't know. I believe that some of that is in his bill. Yes, sir.
Yeah, he has a 1 week filing or appeal and then a 3-week period. But that's the Merit System Protection Board that you believe is allowing a physician who surrendered his license in the state of New York and is still the chief of medicine for the VA Medical Center in Miami. It's that board that's allowing him to stay in his job?
So we need to look at this case. I found out about it this morning. I do not have all the facts on it, but we do need to look at it.
Okay. Thank you. Mr. Michaud.
Thank you, Mr. Chairman. That same position that the chairman talked about, is that a Title 38 employee or SES?
That is a Title 38 employee, sir.
Title 38 employee. Have you looked at, as you know, we passed the chairman's bill before the break, and actually I have HR 4399 that deals with Title 38 and metrics and performance standards. Have you had a chance to look at 4399?
I'm sorry, sir, not in detail.
And is that something when you look at metrics and performance standards, ask you to look at that, see whether or not you might want to implement that administratively, because one of my biggest concerns with the bill that we had previously is it leaves out 80,000 Title 38 employees where we actually, a GAO report stated a doctor let his license expire and he still got awarded. And when I asked the VA about that situation, they said that that was not part of the metrics. For me, if you're a doctor, you should have a license. So I'd encourage you to look at that legislation to try to implement it immediately versus having to try to get it through the system. I also want to say, Mr. Metkowski, I do agree with what Mr. Jolly said. Really appreciate your candidness and your willingness to be forthcoming this evening. It definitely is refreshing to hear you come forthcoming in that regard. My question, actually getting back to the PC, you mentioned the PC3 contracts. Are they reducing delay in accessing non-VA care?
What we are witnessing with PC3, we have a service level. That service level is that veterans must be scheduled and have their appointment performed within 30 days. And that should be true 90% of the time. We are not at 90% of the time, but we're north of 70% of the time. And most networks in most regions are now above 80% of the time. And I think we'll stabilize at around 90% plus. And there are certain incentive payments that we'll make if the care is delivered more timely.
Okay. You'd mentioned about resources and your some facilities, well, there's about $300 million, I believe you said, additional for some facilities. Taken into consideration that your budget was put forward with the wait times at 14 before this whole issue broke, do you anticipate, in order to take care of that huge backlog that's out there that we never anticipated, that you're going to need more resources to deal with that particular backlog? And if so, how much?
Right now, we know of a requirement for 300, and we've been able to identify how we can allocate resources to address that. Those funds will be made available starting tomorrow to the field. I think the entire amount our Chief Financial Officer is committed to release tomorrow. And then we'll track the execution of those funds. Over the next 30 days, we're going to perform a more detailed review. I don't know what that review is going to return, but if it identifies that we require additional resources, we will come back and notify this committee.
All right, but you're moving that $300 million from somewhere else within the VA, the department, so where you're moving it from, isn't it going to hurt those particular areas?
Well, it may. I mean, I think in one potential case, it might be using some of the carryover as a target for those funds.
Okay, you heard Mr. Johnson talk about the IT architecture. If you look at the bill that we passed all here unanimously in committee dealing with advanced appropriation, but it also calls for planning, a quadrennial report, as well as a 5-year planning process within the VA so you can focus on where you should be. And at that point in time, I believe the VA, I don't believe it has taken a position or you were opposed to that advanced appropriation. Have you reconsidered that, particularly the planning process?
We have actually introduced some new planning processes for our budgeting. So one of the challenges we have is when demand or the realities on the ground are different than some of our planning assumptions, it's harder for our system to react than, say, a private sector that's going to be based on revenue. But we are using some of those principles today. We call it, I think, PPB&E, planning, programming, budgeting, and execution. So some of those principles are coming in already.
Okay, thank you. Thank you, Mr. Chairman.
Thank you very much, Mr. Lamborn.
Thank you. Mr. Metkowski, I'm glad to hear that the VA is going to use some of the, I think it's $450 million of carryover for fee basis. I know I was calling for that 2 weeks ago. So you're going to use 300. So that takes care of the money side of it. On the medical side, what problems do we have to look for? For instance, if someone goes in and out of private care from the VA system, like the potential of losing records.
Right.
What are the medical issues that we have to be cognizant of when they go back and forth using fee basis? And I think we have to use fee basis, don't get me wrong.
I think we have to watch that very carefully. I think one of the things we've also learned in our audit is that we need to ensure that there's sufficient non-VA care coordination staff in facilities. It's not, you can't simply fee to the community and assume it's going to take place. We have to coordinate that care. Part of that coordination is the transfer of medical records out. The other part of it is the transfer of medical records in. With PC3, where we have a contractor or other contract arrangements, we can stipulate terms in the contract. In a lot of our non-VA medical care, it's an individual authorization. It's a little bit harder to specify that, but we have to be careful about that. I know with PC3, we currently have a requirement that the data come back upon the delivery of an invoice, and it's partial terms for payment, right? So in order to go to the processing of the payment, we are required data. It's not in a computable form, it comes in a PDF form. We are researching other ways in which to use something called the Nationwide Health Information Network to transfer computable data. And we're going to see if we can build that into some of our contracts as well. But we have to be careful.
Well, we really need to use more fee basis. I believe that the chairman's legislation that the House is going to consider takes a big step in that direction, at least for the backlog.
Yes.
And I think we're going to need it even beyond that. And for Dr. Draper, I have a question on fee basis. What obstacles do veterans face right now under VA policies for using fee basis? I've talked to veterans who didn't even know that it was available. That's one obstacle. They don't even know it's out there.
Right, and I think as the case that that I described in my oral comments, it's just, and I think it's been talked about here, is the coordination is really critical to make sure that the veteran and the VA Medical Center and the non-VA provider are coordinating and that the patient records are getting transferred appropriately, information getting transferred back and forth, because it's really difficult for a patient or a veteran to navigate any health system. So they're dealing with really two separate systems. So I think that's an added complication for anyone using a separate system.
And Mr. Griffin, do you see other problems that need to be overcome as veterans have more awareness and ability, I hope under pending legislation, to use fee basis where there is a backlog?
As has been stated, it has to be managed very carefully. We have done audit work in the past of both inpatient fee basis care and outpatient fee basis care. And the financial management processes were not there sufficiently to preclude duplicate payments for that care. Payments to a medical center that billed for the doctor's care as well as the care for the hospital facilities. Separate bill came in from the provider. So we have been working with VHA on that, and Mr. McCoskey is one of the leads on trying to make sure that with the internal controls for that $4.8 billion are in place and we're getting what we pay for. I still think the bigger question is you got to figure out what the balance is between full-time VA staff. You'll always need some fee basis, no question, especially in rural areas that are removed from the metropolitan areas where the old medical centers are located. But we got to make sure that it's a good business decision to go in that route as opposed to hiring more full-time staff that's committed to working with veterans.
Thank you. Mr. Metkovsky, do you have any final comments to my question on fee basis?
Yeah, one of the items that we're working right now is to structure some regulation as well that makes it clearer. Not all of the authorities that are in statute cover all within terms of fee. And we're making some efforts to allow us to use other forms of agreements in the same way. And I think that's important as well. The IG has noted that we have had historically certain deficiencies in the use of our authorities. We've tried to correct those, and now we're trying to regulate them.
Thank you very much.
Ms. Brown, you're recognized for 5 minutes.
Thank you. And first of all, I don't mind being the minority on this committee. And I think my voice is a little bit the minority on this committee. VA is just as good as our stakeholders. And for example, DOD, it's seamless transfer, it's not happening. So that's part of the problem. But Mr. Griffin, I don't want to go out and hear on the news, and you know how the news blow everything up. I know it's not us, it's just the news, that we got how many investigations and criminal investigations going on. You are, because we have a whistleblower, doesn't mean that the facts gonna check out. Is that correct?
That's correct. I think I said we were investigating allegations.
Absolutely. And allegations does not mean criminal.
That's to be determined. That's why we're doing the investigation.
Fine. I mean, I think I don't want my veterans to feel like that they're not getting the proper care. And I really have not heard that the care is not the quality. It's the timeliness of getting the service. Can you correct me on that?
I think there are private sector surveys that show that veterans are satisfied, more so than some private sector facilities are satisfied with the care they get at the VA.
Absolutely.
But part of quality is timeliness also.
Yeah, I understand that. When I don't show up for an appointment, they charge me. You know, like if I have an appointment at Mayo, and if I don't show up, they still give me a bill. Now, we don't penalize our veterans in that manner. And this fee-based for service, we need to be careful because it could be a slippery slope. Veterans like the care that they get in the VA facility. I don't have any problems in making sure that in some cases, that we use private providers. But we've got to make sure it's the same quality, and we've got to make sure that we still have that we're making sure, as Ms. Drake said, that we have the same kind of coordination. Somebody want to respond? I don't have but a couple of minutes.
No, I agree. It has to be quality. But as I mentioned earlier, I think the best quality is an integrated system. And the more of the care that gets farmed out, the more you lose on the integration aspect and the keeping track of the care that was provided in the medical record for the veterans.
I have this report from the Washington Examiner, and it talks about the clinics, outpatient clinics, and it cites Jacksonville as having the largest delay, 13 years. I want to turn this in, and I want to be clear that this is not correct. I don't know who did this survey, but I met with the mayor, I met with Shands, I met with the VA, and it didn't take us 13 years to get our clinic done, but we have one of the best clinics in the country, and I'm very pleased with it. But when you're dealing with developing clinics, you got a lot of stakeholders, including buying the property, working with the city, working with the permitting, and so I want to turn this in, and it did not take 13 years for my clinic to be built. So I don't know who's doing this research, but it's not correct. Secondly, I want to give to the chairman an article that I read today on the way to Washington in the Times Union, the paper in Jacksonville, where the state of Florida is suing the VA because the state want to come in and investigate the VA. At some point, Mr. Chairman, you need to deal with your governor. Pass this over to him.
I'll deal, Ms. Brown, I'll deal with my governor when you deal with your president.
And that
Mr.
is
Bilirakis.
No, I got 32 seconds. Mr. Chairman.
Ms. Brown.
Now, you know, that is not a good comment. And I just think you owe me an apology for that, because the fact is the VA, the state of Florida is sending people into the VA. That's like sending them into the military. That is not acceptable. It is not a joke. Now, this president.
Your time's expired. Mr. Bilirakis, you're recognized.
Thank you, Mr. Chairman. I appreciate it very much. A couple questions. To follow up on Mr. Lamborn's question, Mr. Makowski, what percentage, currently, what percentage of the health care is outsourced or farmed out, whatever, on the fee basis, in other words?
So Roughly about 4.8 billion, which is about
what percent?
It's about 7 to 8%, sir, somewhere right around there.
8%.
Yeah. And then, you know, we also have state veterans homes that provide us long-term care, and that's a slightly larger number. I think the total expense would be somewhere around $5.5 billion, which is closer to 10%.
All right, thank you. Let's see, I'll move on to Mr. Griffin. Sir, in your testimony, you stated that the OIG has issued 18 reports that identify deficiencies in scheduling within the VA since 2005. Can you elaborate on some of the recommendations identified within your reports?
I'd like to give Lynn Halliday, our Assistant IG for Audit, who directed most of those reports, an opportunity to answer that question.
Absolutely. Is it okay with you, Mr. Chairman?
Please, Ms. Halliday. Thank you. We're glad that you could join in the conversation.
Thank you. In the audit of VHA's outpatient scheduling procedures, when we really started work in 2005, we had identified that the national electronic waiting lists could be understated by as much as 10,000 veterans. At that point, and we were early in our careers, we made recommendations to improve the oversight, overscheduling procedures, and to come up with standardized training programs for scheduling. At that point, we had found a lot of inconsistencies at the sites we went to. Then in 2007, we had another major audit, our audit of VHA's outpatient wait times, where we looked at consults similar to what Dr. Draper had looked at. And we started working there to look at the issues that are actually going behind the waiting times. There was debates on whether the numbers are more correct, only overshadowing the primary points in our early audits. We came to the conclusion that VHA's scheduling system was incomplete. It was not providing reliable information. We made, again, recommendations for addressing the delays in obtaining subspecialty procedures. We continued to look at the quality of care, and then we moved on, and we took on looking at wait times in a VISN network, VISN 3, and we again found that the scheduling procedures were not followed. There were systemic problems throughout VISN 3. I would point out on that particular audit, we had non-concurrences with the recommendations. We wanted VHA to establish a formal scheduler national training program, something with some more rigor to it, so we would eliminate some of the inconsistencies with the scheduling. We wanted required audits of the scheduler's performance. We definitely wanted to make sure that the national reporting software linked the consult create date with appointment creation dates. Some of this is very technical. We tried to work with VHA throughout these various issues. There was a lot of resistance to really accepting the fact that there was a major problem with the inaccurate scheduling and not having reliable data.
What were their responses to your requests? I mean, give me an example. When you talk about resistance.
Resistance, in the VISN 3, I thought it was sort of the tip of the iceberg. There were complete non-concurrences with the recommendations made. They didn't feel that it was necessary. They didn't feel that they had a major problem. I think our more recent work, I know Mr. Matowski's been far more receptive to working with what we've been telling them about how to go about fixing some of these problems. You have to have good documentation of what your demand is for scheduling in all of these various EWLs, or you're never going to have good information to make the decisions you need to make. So in working and trying to tell and change a culture in VA to hold facility directors accountable so that you get integrity over your information is really key. We've stayed in that area as far as our recommendations.
Do they have the necessary funding? The VA has the necessary funding to implement these recommendations, in your opinion? Mr. Griffin, Ms. Holliday?
Funding was never given as a reason why not to implement these recommendations. I believe as we started to tailor that, yes, and they had money for the replacement of their scheduling package.
Thank you so much. Appreciate it.
Thank you, Mr. Bilirakis. Mr. Kano for 5 minutes.
Thank you, Mr. Chairman. Mr. Griffin, I just want to examine more this statement you made earlier about the proper balance between fee basis and the full-time work of the veterans healthcare employees. So your sense is that we really should look at the fee basis as a way to sort of deal with access to healthcare and maybe some of the rural areas, and but that our greater efficiencies over time are going to be with an integrated approach to healthcare.
I think you'll always need fee basis as a safety valve.
So you see it as a safety valve?
But I think you need to make a business determination based on the number of veterans coming into your facilities. You need to determine, based on staffing and performance standards, how many full-time doctors you need to take care of that load of patients. And I don't think that analysis has been done.
So we don't really know whether we're adequately staffed with full-time doctors, because the data has kind of muddied the waters, right?
That's correct. Without data integrity, you're without a basis for making the decisions.
Well, what I mean by muddy the waters is that we definitely we can't tell whether it's a shortage that's driving a part of the driver of this problem. Is that right? That's correct. Is it possible, Mr. Matkovsky, as I said it right? Yes, sir. Matkovsky, that not only do we need to look at fee basis, but also maybe arrangements with our federally qualified health clinics in some of our rural areas and areas that are impacted like mine that are not rural, but have a physician shortage?
I think we could. One point that I want to make is that we are looking at productivity, staffing, and efficiency now as we determine our resource level. We do have productivity and efficiency. The efficiency data can be skewed by the timeliness data. That's important to note. But we have academic affiliate agreements that we use through our medical sharing authority, and then we also have other sharing authorities that we use with other federal government partners to include DOD. So yes.
Thank you. And Dr. Draper, if I understand you correctly, one of your concerns about fee basis care is the interchangeability or the seamlessness of the electronic health records that we have at the VA and whatever system they're using in the private care.
Right. It's coordination of care, and that includes the transfer back and forth of records.
And it seems like only one of the ways that IT is being used. You mentioned, Mr. Matkowski, maybe 7 or 8 of the ways in which we use our VISTA system, but that VISTA did set the standard for the actual health record part.
Yeah, no, I mean, I would say that prior to VISTA, there was a general market failure in the world of health IT. It set the standard. It created the standard that the industry grew up around.
So, Dr. Draper, is there a standard in the private sector healthcare or is it a multiplicity of different kinds of health record?
I think the latter, and systems use different things. But
so
there are probably practices from the private sector that could be looked at.
So we've had trouble trying to connect DOD and their health records and VISTA, but you're saying with regard to the private sector systems, there's even a greater challenge posed by the fact that we have a multiplicity of health systems out there. What about our FQHCs? Do they use a standard at all, and would we have problems integrating with those?
You know, I think that there is an initiative that is still in its early stages of deployment. Maybe folks here have heard about it, but the Nationwide Health Information Network, I think NHIN is what it's called. We have pilot deployments. We have sort of led some of the industry in that, both with DoD and with private sector. I know we've been working with Kaiser to actually establish interoperable transfer of records. It's a long way away from being, you know, completely ready across the country.
Have we given much thought about what it would take for proper oversight with an expanded fee basis relationship?
We need to make sure that when we're using non-VA care, this is not a direct answer. I don't know that we have the specific answer today, just to be candid and direct.
Okay.
And we need to know what it's going to take to coordinate it correctly.
Thank you.
Thank you, Mr. Takano. Dr. Rowe, you're recognized. 5 minutes.
Thank you, Mr. Chairman. I'm going to give you a simple principle that will make the VA better tomorrow. And that principle is if you walk on a VA campus and ask who do they work for, they'll say the VA. The answer should be the veteran. And what I used in my practice for 30 years was, and it was philosophy in my practice, was we don't work for the insurance companies, we don't work for the hospital, we work for the patient. And if you will do just that and put that culture in, the VA will be better tomorrow night. And bring that culture from the top all the way down to the person sweeping the floors at the VA. I promise you it'll be a better organization. So you'll take that back. I have a couple of things I want to ask you about. And along the fee-based, if a veteran is in a situation where they cannot be seen, they're on a long wait list or whatever, and this is a qualified veteran, and they want to get TRICARE for life, has anybody thought about just, look, here's TRICARE for life, that's your insurance policy now as a veteran, and you can go utilize that. Has that been thought about?
We have, and in some cases, we have DoD sharing agreements where we recognize TRICARE for life as a beneficiary, and we'll establish a sharing agreement and do a reimbursement there. So we have done that as well.
And that could be a possibility of helping the VA out.
Potentially.
Another question, you mentioned that in Ohio, I think it was, where veterans literally in a week or two, y'all cleared out that backlog. My question is if that happened, why did it ever occur? If it was that easy to clear out?
I wish we had done now what we had done now 10 years ago, just to return this focus on speed of care, ensuring that we get to good data, and then frankly, returning our management practices with veterans in the center of it. That's all I can tell you.
Okay. Well, let me go with a couple other things. First, on data sharing. I was on the private side as a veteran. I worked in a community with a VA hospital. The problem I had was getting information from the VA to tell me why the patient was in there to see me. So that's an issue also. The VA doesn't share information about drugs that are prescribed, and we have a huge prescription drug problem in Tennessee. We can't not get that information. Yes. And that's, the VA needs to be more forthcoming in their sharing with data also with the private sector. And I want to, that's just a comment. I want to very quickly, because our time is limited, the audit findings, intermediate actions that were the bullet points that we have right here in front of us. One is to suspend all VA senior executive performance awards for 2014. I've never yet had anybody explain to me, what are those metrics? And you don't have time tonight, but what do I do to get a bonus? I bet there's not anybody on this committee that can tell you. I can't, and I've been here 5.5 years. So I want to get that written. And we'll remove the 14 performance goal from employee. VA will revise, enhance, and deploy scheduling training. VA will implement a site inspection process. When will that occur? That's intermediate. Is that going to occur in a week, in a month, in a year?
Some of those have actually already occurred. We promulgated instruction this morning to remove the 14-day performance measure from all staff. We've come up with a mechanism that allows us to have the medical center management, each one of them, report and record all the staff where we have amended their performance plans to remove that. That occurred
So if we come back in 90 days or in the fall when the chairman holds another committee after the August recess, we can assume that all of these things will be implemented on the intermediate action?
On the immediate, sir, yes.
Okay. Number two is audit findings, long-term and other actions. And I want to know what long-term is. The VA, and there are 5 bullet points that you have here. When will that, what's the timeline on those?
Some of those extend out about 6 months and others about 12 to 18 months, but none of them are stretching out much more than 12 or 18 months, sir.
Okay, so we'll have a 90-day or so on the first,
Yes,
I'm
sir.
not going to hold you to exactly, but approximately 3 months on the intermediate, and then the long term will be 18 months on the outside.
18 months on the outside, correct.
Okay, is that correct? Okay, that's something I want to get on the record because these are all good things, I think, that you have on here. Mr. Chairman, I yield back to balance my time.
Thank you, Dr. Rowe. Ms. Brownlee, you're recognized 5 minutes.
Thank you, Mr. Chair. Mr. Makovsky, I wanted to ask you, we've talked a lot about training or perhaps the lack of training for schedulers across the country. Were the schedulers trained to raise the issue of fee-based services? I'm sorry, Mr. Veteran, I'm not able to set an appointment for you on a timely basis, but you do have this option to go to a private practitioner.
We used that just now in the accelerating care, and I think I had mentioned that there were roughly 1,800 or so employees who were trained for that. And part of it, we developed a script on how to offer care for veterans. That is new. That is now part of our standard training.
So it's now part of the standard training, yes. But it hasn't been part of the training.
It had not been before, no.
Previously to that. I want to thank both the GAO and the Inspector General for being here, and certainly I want to thank you for your persistence in trying to make the American people and all of us aware of the magnitude of the problem. I don't think we still fully understand the magnitude, and I don't think we will until we get all of the data in. But we will get our arms wrapped around the problem, and I appreciate, again, your persistence with that. Once we do fully understand the magnitude of this problem and the depth of this problem, I wanted to know what you see as your role as we move forward. As the VA tells us we are going to implement this, this, and this, and we have discovered that we need to do this. And we're going to need some timely feedback as we proceed in that direction, and some help and guidance in your assessments of, is this the right direction to go? And is the VA doing what they say they're going to do? So if you could comment on that.
I would say that I am pleased that it appears we're at a tipping point, and we are going to see actions taken in order to address this problem that's been identified for many, many years. I refer back to my trust but verify comment earlier. We're in the oversight business. Our auditors and our healthcare inspectors will be going to VA facilities checking on things. I think there'll be some other specific recommendations in our final report that will deal with accountability issues and
but once you give us
certification. I mean, there have been occasions over time where after the Schoenhardt memo from 2010 was put out, addressing all the various schemes, as it was referred to in the memo, to manipulate data. For a short while after that, there was a requirement that directors certify that their facility was in compliance with BHA regulations for scheduling, and then that disappeared. So I think when you identify a problem and you make the head person accountable to certify that that problem doesn't exist there, there's no reason to take that certification requirement away. Let's keep it there and make them certify annually, and then we'll go check. And then if they lied about the activities at their facility, then somebody should hold them accountable for that.
Thank you. Dr. Draper?
Yeah, well, we work at the request of Congress, and I think much of our work in the past has been really related to concerns that are particularly around the scheduling and oversight of the scheduling and wait time process. So, I think that our work going forward, that certainly will be at the request of Congress, but to really continue what we've been doing in the past, making sure that the strength of the policies and procedures, that they're playing out the way that they should at the local level, and to make sure, or to look at how VA is conducting oversight, which we have found to be problematic, and really to make sure that things are being carried out the way that they're supposed to be. So we're an independent voice. We're nonpartisan, and we do provide an independent evaluation of many of the programs.
I know I only have a few more seconds here, but would either one of you comment on how you feel about the accuracy of the data that was collected in this nationwide audit?
I would say that it was a proactive attempt to determine if they had a systemic problem or not. I think the process had its limitations in the manner in which the questioning was conducted, and there was no attempt by design to have accountability as part of the process. This initial phase was just to determine to what extent do we have a problem, and to that extent it was successful, but it was with its own limitations.
Thank you. I yield back.
Thank you, Mr. Brownlee. Mr. Flores for 5 minutes.
Thank you, Mr. Chairman. Mr. Griffin and Dr. Draper, this question is for you. I mean, the testimony tonight and earlier reports that we've gotten says clearly that we have a reporting problem related to the appointment system and waiting time calculations and the way those have been reported. Did your studies of the VHA find any other reporting issues that we have to be worried about? I mean, one of the things, the VA comes and gives us plenty of testimony, and they always are armed with reams of reports. But if we can't trust these reports related to waiting times and patients seeking care, that calls into question other reports. Did either of you find anything in your studies that indicate to us we've got other reporting issues to be concerned about?
Well, we have found data reliability issues with both the wait times and the consults data, the work that we're currently doing. But I think there's another issue. It's not just about the data as well, because we found, and we reported in our 2012 report, that another issue is some of the support systems that go to support the work to schedule appointments and get veterans in for timely care. One of the big things was telephone access for medical appointments. We found that phones, they weren't being answered. You call the VA medical facility. Even, we got complaints from within the facility that people would try to call a clinic and no one would answer the phone, or no one returns phone calls. So I think it's a complicated issue. It's not just about the process itself, but some of the supporting systems that help support some of that as well. That's problematic. So it really needs to be a holistic look at how to improve the overall process.
Mr. Griffin.
I think the decentralized nation, or VHA, with 1,700 points of care around the country between the medical centers and the outpatient clinics and various other places where care is provided, makes it very challenging to try and stay on top of what's happening at all those facilities. As I mentioned earlier, when we did an audit of the VISN network, they're all different. Seems like you need to have a better organizational structure that applies to all of the networks. And as was mentioned earlier, the people at the network seem to float back and forth between medical centers and what have you. Now, you either need them or you don't need them. Maybe we need them on the front lines providing health care as opposed to being administrators in networks that were supposed to be Spartan in size when they were first established, and they just kind of grew, and again, they all look different, both from a management structure and from the way they handle contracts.
Okay. Thank you for the testimony. I just have some comments for our VA leadership. I think Americans have received another disappointing reason to not trust big bureaucratic government. I mean, we've had the the VA disability claims problem that's been out there for quite a while now. Now we've got this new VA issue. Over at HHS, they spend several $100 million and can't build a website for the Affordable Care Act. And so tonight you all have heard comments, when I say y'all, Mr. Matofsky, and I'm assuming some of the VA management's listening to this tonight, but you've heard comments about things like this: question everything, what's the next big idea, form a special operations team, try to institute a culture of putting the veterans first. I would say you need to do all those things as you're trying to create the VA of the 21st century. And it should be one that's focused on less bureaucracy and more on taking care of the patient. And that may be a totally different model than what you've got now, which is a heavy, bureaucratically structured system with a lot of bricks and mortar. So I would urge you to think outside the box. If we truly put our veterans first, then I think that we're going to find there's a new model needed to do that versus what we're doing today. Mr. Chairman, I yield back. Thank you.
Thank you very much. Ms. Titus, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Matofsky, like all the members here, I'm concerned about the facilities in Nevada that are on the list for further review. It's our new hospital and it's a clinic in the Southwest. So the sooner you can get that information about the specifics, the better, because we had one news report that kind of confirmed one former supervisor at the hospital had been encouraging these scheduling practices that we've been talking about, and I'd just like to see those details if you can get them to me. My question, though, is about the goal that y'all announced today of notifying the 90,000 veterans and trying to help them either get an appointment or see a doctor in the private sector. And you had some 57,000 that were waiting to be scheduled and another 64,000 who had enrolled in the VA but had never been to an appointment. I wondered if you could outline for us kind of which populations you chose to notify, how you're going to go about notifying them, and then if you could get the information to me about how many in Nevada will be part of that 90,000, I'd appreciate it.
I will do that. I don't know if that was a question right now.
No, I know you'll have to get that back to me, but just in general.
In general, what we did for accelerating care, we did not have the new enrollee appointment request data yet. That was a recommendation coming from the IG, and we worked on that over a couple of weeks and finished the list in time to publish today. What we focused on was veterans who did not have an appointment yet. That was the 57,000, and veterans who we knew were waiting for care and they were new to their clinic and we could identify them for wait times. That came together for roughly 90,000 veterans, and that was just the start. It's not where we stop. We also encouraged facilities to focus, if they knew their near number, to pull that and request funds for that. If they had established patients that they knew wanted care sooner, to work that list as well. And that was what went into the $300 million. We're starting, I think tomorrow we'll be able to make the data available to the facilities. We had to correct a defect on the near. We did correct that, and we're asking facilities starting tomorrow to have an engagement plan for every veteran on that new enrollee appointment request list, that entire contact to be done in 30 days. If they cannot do it, we're going to use the process that we used for Phoenix as well. We used our national call center in Topeka, Kansas. That national call center jumped to action right away, scripted the calls, and contacted all of those veterans and more in a short period of time. And so our goal there is for the remaining 64,000 on the near in less than 30 days.
Okay, thank you. If you'll get that information to me for Nevada, I appreciate it. Thank you for staying with us tonight. I'll yield back.
Thank you, Ms. Titus. Ms. Huelskamp, thank you for yielding your time. You're recognized for 5 minutes.
Thank you, Mr. Chairman. Appreciate the opportunity to ask questions. I will note at this facility I was at, I had more than 5 minutes, and it worked out much better that way. But I'd like to follow up on a couple things. Putting together the OIG report with the numbers today, Mr. Matofsky, you mentioned 64,000 roughly that are on the near list and 57,000 that are on the electronic waiting list. If I understand and recall the report from OIG last week, the NEAR was considered an unauthorized waiting list. But in addition to that, they'd identified at Phoenix alone 600 veterans that were in other type of unauthorized waiting list. And so if the averages would hold the numbers, that would identify 30 to 35,000 veterans on other unauthorized, hence secret waiting list. Do you have any data on that was shed the light on? Because again, that was 1/3 of the total at Phoenix. You haven't referenced it all in your report today.
Sure. So for Phoenix, I believe there were 3. I would let Ms. Halliday actually correct me, but I believe there were 3 sources of data in addition to the electronic wait list. One of them was the new enrollee appointment request. The other was a consult for an appointment, typically coming from the ED to primary care. And the last one, I believe, was the helpline. That helpline process is stood down. That was not an appropriate process. They have now moved somebody into their call center who actually manages the EWL for them. The consult for primary care appointment would get picked up in our consult review, though.
Okay, what are the numbers for that? How many are waiting?
I don't have that tonight, sir.
Okay, so that would be not included in the 64 nor the 57. Do you have a rough estimate of how many other veterans are in that list?
Sorry, the correct process for processing a consult for an appointment request is to either schedule that appointment timely, or if you cannot schedule that appointment, to have it in the EWL. I
understand that. The OIG referenced 200 veterans in the consult list out of the 1,100, or 200 there, and then 400 on screenshot paper printouts. So again, that was about 1/3 of the total. So are you picking up these other unauthorized lists, and any guesstimate of how many nationwide? Because that would be beyond the numbers you revealed today. Sir. Is that correct?
So as we continue to report this, bi-monthly we're going to report these data out. It will change. There will be more folks on EWL, or as
well, I understand, but how many today are on the consult list? That's, again, an unauthorized waiting list.
I'm sorry, but the consult process is not an unauthorized mechanism. What is not correct is to not act on that. And that's what Phoenix did not do. That was what was not correct. It is correct to use the consult system from the emergency department.
So I'm about out of time. So the OIG was inaccurate in calling that?
No, not at all. They were accurate. What they were saying was...
So how many are on this consult list?
Nationally, I do not know. Okay. We can get that data.
Wish you would, because the media is reporting 57,000, and then the near list of 64,000. What I'm saying is, by my guesstimates, we're talking about another 25 or 30,000 on unauthorized list separate from those. In addition, going back to the VA report from April of 2010, they also identify manual logbooks. Is there any evidence of manual logbooks being handled in any VA facility?
I don't have any evidence, but we did not do an evidence collection process for manual logbooks. Okay. Those are not to be used.
Well, so is block scheduling is not to be used. So is consult management and playing with the desired date. And again, these are all unauthorized. So that was my question.
There were some handwritten lists that have come to our attention in the course of our work, and we're pursuing those as to who created them, at whose direction, and so on.
Were any of those found in Phoenix, Mr. Griffin?
Not a handwritten list per se. There were 400 or 500 desired appointments that were in someone's desk drawer that were not, officially accounted for at the time that they were given to us.
Okay. And lastly, Ms. Griffin, we have a report of the OIG's investigation at Richmond VAMC, where the investigator arrived at 12:10 p.m., searched one room for a document shredder, and left the premises 10 minutes later. Can you give me the criteria of these type of searches? If it lasted 10 minutes, only involved one room? Is this...
That's not familiar information to me. I'd be happy to take that for the record
and
determine whether or not it really was an IG employee or somebody else.
Okay, and lastly, also disturbing reports the VA has insisted and been allowed to have representatives present during the OIG interviews of scheduling clerks. Is this the case at all?
No, I think that is the VA audit. We've had a couple of directors try and barge into one of our interviews, and we threw them out.
Okay, even though they have an investigation going on at the same time, those are entirely separate and have not interfered.
No, this would be a medical center director who was trying to impede our interview with their schedulers.
About general counsel?
And we threw them out of the room.
Any union representatives in these investigative meetings?
Not in ours.
Okay, I yield back, Mr. Chairman. Thank you.
Thank you, Mr. Huelskamp. Ms. Kirkpatrick, you're recognized for 5 minutes.
Thank you. Mr. Makowski, I'm going to join my colleague from Nevada's request for data relative to Arizona. And this is a concern I expressed at our meeting last week, that I represent a very large rural district, and it has 12 Native American tribes, and a lot of those folks don't have telephones, and they don't check their mail for months. So I just want to make sure that we're contacting them, and I visited with some of the VSOs in Arizona when I was home last week, and they can be helpful in that process if we need that, but just want to express that concern. And then my question is a follow-up question on the audit that you put out today regarding further review. And I just want to read these first two sentences. It says, as a result of these audits, some locations were flagged for further review and investigation. Any instance of suspected willful misconduct is being reported promptly to the VA Office of Inspector General. That's good. Here's my concern. You then go on and say there are 3 locations in VISN 18 that require further review, and one of those is Prescott, Arizona. My concern is do I read this to think that there could be suspected willful misconduct at the Prescott facility? And what was your criteria for singling out these locations for further review?
Just to give a sense of the limitations that Mr. Griffin alluded, we started, I think it was on Tuesday before the week of May 12th to plan this out. I think that night, May 11th, which I think was Mother's Day, most of our staff dropped everything and went to the field, and our goal was to complete the entire audit of all of our major medical centers and our CBOCs with 10,000 or more patients.
And I appreciate that. Thank you.
It allowed us to interview 9 people per facility and 1 clinic manager per facility. The rules were that the staff member could have a union representative present if they so desired. If they did not need to. And if they didn't want to participate in the interview, they didn't have to. That did not allow enough quantitative data to say we have a representative sample. But the site audit team, which was comprised of 4 senior people, wrote a report. One of the questions we asked them to answer is there something you want to tell management about what you found in your site? If they said yes, they constructed a narrative response, and we read that narrative response and matched it up with qualitative responses on those questionnaires and determined there was a practice that we thought was inappropriate that involved changing dates. And that was the criteria. It was really qualitative, and we were using a combination of the quantitative data, but frankly, these were leaders in our organization, and we used their judgment.
Thank you. I am very concerned about that at the Prescott facility, and we'll follow up with you more. I'll be very interested in your final review on that, but thank you very much, and I yield back.
Thank you, Ms. Kirkpatrick. Dr. Winstrup, you're recognized for 5 minutes.
Thank you, Mr. Chairman. You know, I recognize that we have a lot of great caregivers in the VA system. There's no doubt about it. And a couple from my own private practice would go 1 or 2 days a month to operate at the VA. My question comes in is how much caregiver or physician input is available to the administrative end of the VA system? For example, as well, I asked Dr. Petzel one time when he was here, I said, how many of the administrators have been providing care? And he said, well, we've all been in academia. So I think there's a component missing there that's valuable input. And I wonder, you know, if our providers are ever asked, what is it that keeps you from seeing more patients and being more efficient? Do they have the opportunity to have that input? Because besides the love of work and taking care of veterans or just taking care of patients in general, what is their incentive to see more patients? And then do they have the ability to provide input and make change? You know, we talk here about things on a national level. Well, every place can be a little bit different and every practitioner is a little bit different. And so do they have the ability to say, you know, if I had 1 more medical assistant, I could see 10 more patients in the same amount of time or something along those lines?
They do, and we've collected some of that data in some of our other questionnaires, and we've used that. I just wanted to make one statement, if I may.
Sure.
You know, our staff on the ground give great care. They are committed. They are good people. They take care of veterans every day. Sometimes we don't give them the resources they need, and we need to fix that. The problem here is having inaccurate data that can't tell us where we need to fix things. And that is a systemic problem. We have to fix that. But some of the issues we find are simple things. You know, having enough housekeeping staff to actually help turn the rooms around so that they're quick and ready to use for the next patient. Having a system that is easier to use and interface with so that instead of looking at your screen, you're looking at your veteran and you're having a conversation. Having additional clinic support staff to make that easier to do. Having access to modern technology in a timely basis is also a challenge. Adequate space for meetings, for collaboration, for private offices for mental health. These are all challenges they tell us, and we need to open that up. We need to listen to the front line, and we need to find out what they need so that we can provide it to them.
And do you have plans in place for that? I mean, if a doctor's running around getting supplies and things like that, that is a tremendous waste of time.
Correct.
And do we really want to take a look at all the paperwork that a physician is asked to do and maybe isn't necessary?
Oh, absolutely. I think one of the things we hear from our clinicians on the front line is, you've got me doing administrative work when I should be seeing veterans. You've got me tied up doing this and I can't actually do my phone clinic time. And we need to look at that, yes.
Well, I look forward to hearing what you come up with and what the solutions are to allow for that physician or caregiver input.
Oh, absolutely.
Thank you, and I yield back.
Thank you, Doctor. Mr. Waltz, you're recognized for 5 minutes.
Thank you, Chairman. And again, thank you all. And I think I encourage you, continue to push for the transparency, continue to push and do the soul searching to get it all out there. We cannot make good decisions unless we understand what the systemic problem was, if the data to drive where we're getting. And I pulled back up something, Mr. Matowski, from 2006. It says, to help reveal the business specifications of rehosting and modernizing its legacy enrollment system, the VHA brought in Philip Matowski, principal with Macro Design Group of Arlington, Virginia. Matowski is a systems consultant with plenty of experience in the public sector. It's not as if this is a new idea, and I ask all, this is to members of this committee. This is our opportunity. No one was under any illusion that this was anything but a zero-sum proposition. If one veteran gets left behind, we failed. We know that. Your providers know that. We know that in this committee. We have an opportunity to do something big here to get this right. But don't be under any illusion, and you heard it there. So electronic medical records, New England Journal of Medicine, 12.2% of private sector has this. You're not going to have collaboration between the VA and the private sector because they don't have it. They don't have the ability to send that back to you in any way. Vista is probably the gold standard. The people at Mayo Clinic told me it was probably one of the better ones there. And don't be under any illusion, 98,000 people die in this country from medical error every year. Now, I understand it's an art and a science, but we have to do something, and I'm supportive of this. Getting out and getting the care as quickly as we can, but don't think it's a panacea and a magic bullet that you're going to send them to the private sector. Next year, you're going to have a CEO from a private hospital sitting here wondering why your veteran died in that. We can do something. There is a new model here. There is something that can be done, but if we fall back into these old traps, nobody's going to defend any type of bureaucracy, both public or private, if it doesn't work, because Dr. Rowe had it right. What's best for the veteran? What's that model going to look like? And I understand on this fee-for-service, as long as it's a VA medical center director deciding if there can be fee-for-service, the veteran's truly not in charge of his own health care. I get that. We've got to have that model be differently, or you're going to get skewed results. So my, I guess, plea to all of us in here is, we got to keep pushing for the data. We got to have it come clean. We got to put people in jail if they violated the law, if that's it. We've got to let due process do its work. But we have a responsibility both for the veterans and those 98,000 our constituents too out there to improve the system and have accountability. So I would encourage all of you, I'd encourage my colleagues, it's not going to be good enough, and you're not going to be judged by pointing out what the problems are. That needs to be done, but that's a means to an end. The end is improved care for our veterans in a timely manner that is cost-effective to the taxpayers. So I think, again, Mr. Murkowski, you said it, this is a starting point. It isn't even the starting point for us, I would argue. The data's going to come. We need to let the data drive us to where we're going, and then I think it needs to fall back on us. If you really want to get this right, We don't just come at the middle of the night a couple times to try and do this. This is important work, don't get me wrong. We've got to find this out, but the really important work and the legacy will come if we make a difference. And I don't know if we've noticed this. This is a shifting ground amongst the VSOs like I have never seen in 30-plus years of being around this. They are out there ready again to engage in this, but don't bring them in to tell them what you're going to do. Bring them in to give some ideas. Patient advocates, something I told me. I'm hearing this all the time from some of them. Patient advocates to help navigate this system. And if they go into the private sector and that's what needs to work, I'm all for it. That's great. But there's going to have to be someone to help them navigate this. I heard the Vietnam veterans said, if you're medically credentialed, get on the floor. We used to say that, grab your rifle and go man the perimeter. Get on the floor and do it. And as Dr. Wenstrup was right, don't get in their way. If there's forms and other things like that that we can reduce to get them out there, get them out there. They're willing to do it. So that's my rant, but I'm telling you, there's not a person in this room that is not going to be judged by what the outcome is of what we do here, not the talk, not the pointing, whatever. So you guys keep doing your job. Mr. Murkowski, you keep doing your job. VSOs, you keep doing your job. And we have to keep doing our job because it's not going to be, again, not that we pointed it out or found it. What do we do to fix it? I yield back.
Thank you very much, Mr. Waltz. Mr. Jolly, you're recognized for 5 minutes.
Mr. Chairman, no questions. I think that's an appropriate way to conclude.
Thank you very much, members. We appreciate your attendance tonight. To the witnesses, thank you so much for all being here with us. I will tell the committee that we are going to be having 2 committee hearings per week for the foreseeable future, and we will be talking about manipulated wait times, bloated middle bureaucracies, the IT issue that we have heard tonight, among others. So thank you for your attendance, and this hearing is adjourned.